Hello friends, welcome to PW MedED YouTube channel. I am your faculty Dr. Shonali Chandra, and we're going to take up previous year MCQs for FMGE. In this session, FMGE Accelerate. So we're going to take up some important MCQs from Obs right now. So let's see how many of you have joined in. I can see your comments on the chat box. Now, the strategy in today's session will be to look up, the previous year MCQs that have been asked for FMG, and we are going to go in a retrospective manner in the sense that we're going to look at questions and then talk about the important aspects of the topic that has been asked in your MCQ. So goal is to revise as many MCQs and as many topics as possible today. So good evening, Jitendra. Welcome to the session today. So, and Osama Sheikh, good evening to you too. All right, so let's get started and have a look at the first question. So the first question is, which of the following is not a valid indication for medical termination of pregnancy under the MTP Act in India? Now, early pregnancy complications, whether it is abortion, ectopic, molar pregnancy, these are very important topics for your FMG examination. And in the chapter on abortions, every aspect is also equally important. So good evening, PK. Good evening to you too. So let's get started. First of all, let's talk about this legal aspect for abortion in India, which is governed by the MTP Act. So, which is not a valid indication. Very good, Imran and Surgeon correctly answering. Imran, D is not a valid indication. Okay, not a valid indication they are asking. So large family, poor socioeconomic status, these by themselves are not a valid indication. Okay, failure of contraception, or let's say for example there is a baby, there's a fetus who has a gross congenital anomaly or a serious genetic disorder because of which the fetus when born, the child will suffer from severe disability, whether physical or mental disability, then that is a valid indication. Or let's say there is a condition in the mother because of which if she continues the pregnancy, the mother's life is at risk. Like for example, if she has a severe heart disease, then that is a valid indication for termination of pregnancy. Okay, so large family by itself is not a valid indication. Okay, then pregnancy as a result of, let's say for example, rape, okay, which can lead to serious mental stress to the woman, that is also a valid indication. So another valid indication would be pregnancy as a result of rape. Keep that in mind. Okay, so these are your indications. So broadly they will fall under either failed contraception, baby with a serious disability, or mother has a serious condition, or there is a pregnancy as a result of rape. Now, important pointers you need to remember regarding the MTP Amendment Act of 2021. First of all, consent. See, consent of the woman is the most important. Okay, the consent of the spouse, consent of the husband is not mandatory by law. Okay, keep that in mind. If the age of the woman is less than 18 years, or let's say the woman is it's a young girl who's been or let's say it's a young let's say it's a woman who's mentally challenged, whatever be the situation. Okay, if age is less than 18 years or she is mentally challenged and she cannot take her own decisions, then consent of a legal guardian is required. Then MTP, according to the Amendment Act, is allowed now till 24 weeks of gestation. That's a very, very important point to note. In the first 20 weeks of gestation, opinion of only one registered medical practitioner is required. But when MTP is done between 20 to 24 weeks of gestation, then opinion of two registered medical practitioners is required. And also remember that when we are going for MTP for contraception failure, MTP for failure of contraception, that's another important point to remember. MTP for failure of contraception is allowed only till 20 weeks. Okay, allowed only till 20 weeks. Okay, And this MTP between 20 to 24 weeks, it is allowed in special circumstances. Like for example, there is a pregnancy that happened as a result of rape, or there is a severe fetal anomaly which was diagnosed later on in pregnancy. Then in those situations, between 20 to 24 weeks also pregnancy can be terminated, but opinion of 2 registered medical practitioners is required. Then the third important change is that the upper limit of 24 weeks, that can also be relaxed, but only in special cases. Special cases, example, gross congenital anomaly in the fetus, okay, which was identified, let's say, beyond 24 weeks. It's already been 24 weeks and there was a fetal anomaly which was diagnosed very late in pregnancy. Then also the upper limit of 24 weeks can be relaxed, but only in situations when it is approved by a medical board. Okay, so this medical board is going to constitute of a gynecologist, a radiologist, and also a pediatrician, and then the medical board will decide that yes, it is allowed. Okay, so that is an important distinction that you need to keep in mind. So these are certain important pointers regarding the MTP Amendment Act of 2021, and very, very important MCQs can be asked from this. Okay, now let's have a look at the next question. All are methods of first trimester MTP except, so which is not a method of first trimester MTP, that is what they're asking you. Okay, so dilatation and curettage, it's a surgical method. Manual vacuum aspiration, again a surgical method. Mifepristone and misoprostol, these are drugs, so this is a medical method. And then the fourth option is extra amniotic ethacridine lactate. Okay, so very good, Jitendra, you are answering very correctly that extra amniotic ethacridine lactate, this was used earlier, it is we no longer use this method, but when it was used, it was a method for second trimester MTP. Okay, it is method for second trimester MTP. Rest all the methods, dilatation and curettage, or let's say suction and evacuation, okay, manual vacuum aspiration, these are all methods which can be done in the first trimester. Okay, surgical method in the second trimester, surgical method in the second trimester is what is called as dilatation and evacuation, DNE, dilatation and evacuation, DNE. Okay, and we are generally not doing this method in the second trimester, surgical method. We are generally not preferring to do surgical method in the second trimester. Keep that in mind also. So what you need to remember here, very, very important, these are according to the Government of India guidelines. Okay, till 9 weeks of gestation, we have options of both medical and surgical methods. Both are fine. Between 9 to 12 weeks of gestation, only surgical methods are used. Very, very important point. These surgical methods between 9 to 12 weeks, they can be, again, like I told you, suction evacuation, manual vacuum aspiration, dilatation and curettage. Basically, surgical method simply means that we go inside the uterine cavity. We use instrumentation, so it's an invasive procedure. Instruments are introduced inside and the uterine contents are evacuated. How we evacuate the content? Okay, do we curate out the contents? Then it becomes dilatation and curettage. Okay, do we perform suction and evacuation? Then it becomes suction and evacuation. Okay, how do we create this suction? Okay, if we use suction machine that is in the OT, then it becomes an electric vacuum aspiration, so that is suction and evacuation. Okay, if we are creating suction using a handheld device, then that becomes manual vacuum aspiration. Okay, so these are various surgical methods. But beyond 12 weeks of gestation, always remember, when it is in the second trimester, medical methods are the method of choice. We are not doing surgical methods anymore. And then they ask you, what is the drug of choice for this medical method, right? So in the medical method in the second trimester, like we just saw in the previous question also, ethacridine lactate, not using it anymore. Oxytocin infusion can be used, but then very high dosages of oxytocin are required, and we have better drugs now. So for the drugs that are used in the second trimester, okay, the drug of choice are prostaglandins. Okay, now we have variety of prostaglandins. We have PGE1 analogs, PGE PGF2 analogues, PGF2 alpha, and the rest which we read about in PPH and active management of third stage of labor. But you have to pick one drug. Then the prostaglandin of choice is misoprostol. Okay, misoprostol. This is a PGE1 analog. So remember that as well. Okay. Now, they have also asked you questions regarding the medical method. So in the first trimester, the drug that you use is mifepristone and misoprostol. Okay. Now mifepristone is also called as RU486. So don't get confused. RU486 is the same as mifepristone. It is an anti-progestin. Okay. It is an anti-progestational drug, mifepristone. And the dose is 200 milligrams oral. 48 hours later, we are going to give, after 48 hours, we are going to give misoprostol. Okay, so if let's say on day 1 we have given mifepristone, then on day 3 we are going to give misoprostol, and 800 microgram is the dose of misoprostol in the first trimester. It can be given by any route. Misoprostol can be given by oral route also, it can be given by vaginal route also, it can be given per rectally also, but the best is sublingual. Okay, best is sublingual route. Keep that in mind. Okay, and in the second trimester, same thing, mifepristone 200 milligrams oral, 48 hours later, followed by misoprostol. But in the second trimester, remember that the dose of misoprostol is less. Okay, the dose of misoprostol in second trimester is 400 micrograms, and it can be repeated if required every 3 hours, but for a maximum of 5 doses in 24 hours. That's an MCQ. Okay, that's a direct MCQ, maximum of 5 doses in 24 hours in the second trimester. Keep that in mind. Okay, so these are important MCQ pointers for you people. Then in the abortion, they also ask you about the instruments that are used. So identify this instrument here. You can see a cannula. Okay, it's a plastic cannula. It's a disposable cannula. And this cannula is called as the Carman's cannula. This is the Carman's cannula. Okay. This is the Carman's cannula. Okay. Now this cannula, how will you identify? It has two openings. It has two openings, and it comes in various sizes. Okay. That means there are bigger cannulas, thicker, and there are thinner cannulas. Okay. So the number of the cannula basically represents the size of the cannula, or let's say that means the diameter of the cannula in millimeters. Okay, so let's say for example there is a 6 number cannula. It is 6 millimeters in diameter, 8 number, 10 number, and so on and so forth. Okay, so number of cannula is roughly the size of the cannula, that is the diameter of the cannula in millimeters. Okay, then another question they ask you is that this number of cannula, that is also going to decide which cannula we are going to use. Like for example, if we are going to go for suction and evacuation in a uterus that is 6 weeks in size, or 6 weeks is the period of gestation, then we will use a number 6 cannula. And let's say for example, if it's a 8-week size uterus, or let's say it is an 8 weeks pregnancy, then we are going to use a number 8 cannula, right? So the number is roughly equivalent to the number of cannula used is equivalent to the size of uterus in weeks. That's also the same as period of gestation in weeks. Okay, so that's an important pointer. MCQ was asked in this from this point as well in your FMGE examination, right? Okay, misoprostol ki doses in different conditions, very confusing. We have a question on misoprostol in subsequent questions also, so I will definitely tell you S. Just remind me in the end in case I forget. Okay, first let's complete this. Now this another instrument that you see here, this instrument that you see here is the manual vacuum aspiration syringe. Okay, MVA syringe it is called, manual vacuum aspiration syringe, MVA syringe. Okay, how do we identify? It has bivalves. It has two valves. Okay, so that is how we identify. And on this manual vacuum aspiration syringe, we are going to connect the cannula. Okay, we are going to connect the cannula, this same Carman's cannula, and then the cannula can be introduced inside the uterine cavity. We create suction with the handheld device, and then the uterus is evacuated. So the procedure becomes manual vacuum aspiration. You need to remember that manual vacuum aspiration can be done till 12 weeks only. Till 12 weeks only. That's an important pointer. Secondly, they ask you what is the capacity of this syringe. So this syringe has a capacity of 60 ml, and it can create a suction pressure of about 600 millimeters of Hg. Now this much suction pressure is enough to evacuate a uterus that is 12 weeks in size, right? So these are three very important pointers. First of all, identification of the image, manual vacuum aspiration syringe. It can be done till 12 weeks. The capacity of the syringe is 60 ml, and it creates a suction pressure of about 660 mm of Hg. Keep that in mind. Okay, now identify these instruments. See, any procedure that we are going to do, whether it is a manual vacuum aspiration or it is a suction and evacuation. See, in suction and evacuation, what we are going to do is we're going to introduce the Carman's cannula. There's going to be a tubing. Okay, there's going to be a rubber tubing, and the tubing is going to be connected to the suction apparatus, the electric suction apparatus in the OT. Then the procedure becomes suction and evacuation. Okay, now whether we're going to go for manual vacuum aspiration, or we're going to go for suction evacuation, or we are going to go for dilatation and curettage, any method we are going to do, we'll have to dilate the cervix first. Okay, very important, we have to dilate the cervix first. So what are we going to use to dilate the cervix? We're going to use these metallic cervical dilators. Okay, so these are the metallic cervical dilators which are used for dilating the cervix. Okay, now you see here the above dilator, it has, again, the dilator we can only dilate from one end. Okay, so this one is the Hawkin-Ambler's dilator. This one is the Hawkin-Ambler's dilator, and the one below that can be used as a dilator from both the ends, that is the Haggard's dilator. Haggard's dilator. Okay, and again the number of the dilator corresponds to the size of the dilator in millimeters. Okay, and again the dilator that we are going to use is going to correspond to the size of the uterus in weeks. That is the same as the period of gestation. Okay, keep that in mind. Right, now identify the other instrument. The other instrument here that you can see in the image is uterine curette. This is the uterine curette. Okay, so what are we going to do with the uterine curette? Where we are going to use it? Again, we dilate the cervix with the dilators. Okay, and then if we're going to introduce the curette inside, then we're going to curette out the contents. Okay, curette out the contents. So the procedure then becomes dilatation and curettage. How we evacuated the uterus? We did dilatation and then we did curettage. Procedure becomes dilatation and curettage, right? So S, you're asking, first we use Haggard dilator, then Carman's cannula with this uterine sound cup, ma'am. Very good question. So if you look at the sequence of steps, okay, if you look at the sequence of steps, you see, first of all, we have to note the size and position of the uterus. First of all, we have to note the size and position of the uterus. Okay. So for that, how will I do? I will do a clinical examination. I will first of all do a clinical examination, and I will decide whether the uterus feels 6 weeks in size, 8 weeks in size, 10 weeks in size. So note the size and position of the uterus. We can do it by clinical examination. Okay, so other thing that we can do is you can use a uterine sound also. We can use a uterine sound also, but uterine sound is generally not preferred in a pregnant uterus, because the pregnant uterus, the walls of the uterus are very thin. Okay, so generally tend to avoid sounding a pregnant uterus, but it can be done. Okay, so clinical exam will help, uterine sounding will be done, and then we are going to go for cervical dilatation using the dilators, and then we are going to evacuate the uterus. Okay, now how we evacuated the uterus? We may have done a suction and evacuation, we may have done a manual vacuum aspiration, or we may have done a curettage. Right, so those are going to be the steps. Okay, so R Chaudhary, yes, we discussed Carmen cannula size. Yes, same as the weeks of gestation or size of gestation. So giving you an example, if the period of gestation, let's say for example, is 8 weeks. Okay, so period of gestation 8 weeks, the size of the uterus should correspond to 8 weeks, and I will use a 8 number Carmen cannula. Okay, got it? Fine. So these are the sequence of steps. Now let's have a look at the next image. Identify the instrument from the next image. Yes, what are we seeing in this instrument? We are seeing a forceps, right? We are seeing a forceps. I'm holding a forceps in this image, but there is no latch here in the forceps. Usually forceps come with a latch, but there is no latch in these forceps. Secondly, you can see here the ends of the forceps are cup shaped hollow ends are there, right? So the logic is that we introduce them inside the uterine cavity, open, grasp the contents, bring them out, right? So evacuation of the uterus of its contents. So this forceps for identification, very good, as this is the ovum forceps. Very good, this is the ovum forceps. Okay, so generally we tend to use it, you know, in second trimester surgical methods, if at all we are doing. Nowadays we're not doing, we're doing medical methods in second trimester. But remember the logic, that it is a forceps designed in a manner that we can go inside the uterus, grasp the contents, bring them out. So the forceps that are used for that purpose is the ovum forceps. So you need to be able to identify this instrument based on the image. Okay, now let's have a look at the next question. This is also a previous year MCQ from your FMG examination only. So a patient presents with bleeding PV after a curettage was done in a private hospital. Okay, so she has already undergone a curettage at some private hospital. Around 40 cc retained products of conception were detected on ultrasound. A repeat evacuation was attempted, but the curate is found to go deep through the uterus without resistance. So what has happened? That's your clue. Curate was introduced and it just kept on going inside. So this is the fundus, right? We are introducing and we have gone deep inside without any resistance. So most of likely what we have done perforation of the uterus. Okay, while curating. Okay, so what should be your next step? What should be your next step? You realize that we have perforated the uterus. Okay, so what should be your next step? At the undergraduate level, your immediate step should be stop the procedure. Stop the procedure and inform the senior person. Okay, so you can't continue the procedure with skillful maneuvering at the undergraduate level, not at all. Okay, will you give drugs now to complete the abortion? No, that is also not to be done. Okay, so the choice is between stopping evacuation, waiting and watching, and the next option is immediate laparoscopy / laparotomy and manage. Now the perforation has been done with the curate. Okay, let's just have a look at what the curate is. Let's just go back, have a look at this instrument. This is the curate. This end, look at this end. Okay, this is this hollow in the curate. Okay, now this hollow has been when we perforated, this hollow end has gone through and through the uterus and into the pelvic cavity. Now let's say for example, if we look at the suction cannula, look at this. The suction cannula also has got holes, and let's say we have perforated using a suction cannula, so there are holes on the suction cannula, and we were suctioning. So we don't know, you know, whether we have done any you know, injury to the gut or the omentum. We don't know. right? So when we have perforated with a curette or with a suction cannula, there is always this chance that we may have caused some injury to the nearby tissues, like the gut is there, the omentum is there, so for that reason we have to go for an immediate laparotomy or a laparoscopy. Okay, so that's the important clue here, that we have perforated with a curette. That's why it will require an immediate laparotomy slash laparoscopy and management. Okay, so when we have perforated during the procedure, if we have perforated with a dilator, the dilator does not have any holes or anything, right? So the this is my pen. Okay, so this is like, the dilator is very thin, right? So even if you've perforated with a dilator, it's a very clean perforation most of the times, right? So we're going to stop the procedure. Watch for bleeding and vitals. Most of the times the bleeding will subside on its own. Okay, because it is going to be a small perforation, it is going to seal off. So if the patient remains stable, then the procedure can be completed by a senior person, and this procedure can be completed under ultrasound guidance, or this procedure can be completed under laparoscopic guidance, depending what the senior prefers. If the patient is unstable, or let's say the bleeding is not stopping, only it is continuing, then of course we have to explore the abdomen and pelvis. But if we have perforated with a suction cannula or a curette, then we have to stop the procedure first and explore the abdomen and pelvis. Okay, patient does not go home before exploring the abdomen and pelvis, because let's say for example we discharge the patient and she comes back a couple of days later with some gut injury, then that is criminal. Okay, so explore abdomen and pelvis, and how we are going to approach that is another matter. So if the patient is stable, we can go for a laparoscopy. If the patient is unstable, then laparoscopy is not an option at all. Then we have to go for a laparotomy only. So this is important for MCQs. Keep that in mind. Now let's have a look at the next question. Now there is a fourth gravida para 2 lady who presented with a history of 2 spontaneous abortions at 16 weeks and 20 weeks POG. Which of the following could be the most likely reason for these abortions? Yes. So she has multiple abortions, okay? 2 spontaneous abortions, one at 16 weeks, another at 20 weeks. Among the options provided, which could be the most likely reason? Yes. This is a fairly straightforward question. Jitendra and S both answering correctly. It's probably cervical incompetence, also called as cervical insufficiency, right? So it typically causes second trimester pregnancy losses and recurrent pregnancy losses. Chromosomal abnormality are overall the most common cause, but of spontaneous abortions, one-off events. If there is a woman with multiple pregnancy losses, the back-to-back pregnancy losses, then it is called as recurrent pregnancy loss. Okay, so with recurrent pregnancy loss, we are looking at other set of causes. So please remember that overall, if they ask you the most common cause of spontaneous abortion, okay, single spontaneous abortion, then the answer is chromosomal abnormality of the fetus. Which chromosomal abnormality? Most commonly as a group, aneuploidies. So aneuploidies as a group includes trisomies, also includes monosomies also. So aneuploidy as a group, then trisomies as a group, then monosomy X, and then trisomy 16, and then triploidy. If they ask you most common trisomy responsible for spontaneous abortions, and in the options they're giving trisomy 21, trisomy 16, 18, and other trisomies they're giving, then most common trisomy in spontaneous abortion is trisomy 16. Trisomy 16. Okay, so that should be your answer. But if they ask you single most common abnormality, like in the question they say which is the most common abnormality, and they give you options like trisomy 16, trisomy 21, monosomy X, triploidy, then the single most common abnormality, if singly they ask you, then it is monosomy X. Okay, keep that in mind. So remember this order. You remember this order. This order is important. Okay, right? And if they ask you what is the most common cause of recurrent pregnancy loss overall, the most common cause of recurrent pregnancy loss is actually idiopathic. Most of the times we don't identify any cause. So what are the other causes? What are the other causes of recurrent pregnancy loss, recurrent abortions? Okay, so we can have APLA, antiphospholipid antibody syndrome. We can have uterine structural anomalies, okay, like septate uterus, like bicornuate uterus, where the uterine cavity is distorted, right? And we can have in this also septate uterus is most common. Okay, septate uterus is more common than bicornuate uterus. And if the other causes could be cervical incompetence. Okay, so let's talk a little bit more about cervical incompetence. Now, what is cervical incompetence? It's also called as cervical insufficiency. In this situation, there will be history of recurrent second trimester abortions or preterm births. Okay, and there will be a classical history, because see, the cervix is weak. Okay, so there can be the cause of this cervical incompetence could be congenital weakness of the cervix. There could be congenital weakness of the cervix. Okay, so cervix is mainly elastic and elastic connective tissue, mainly collagen. So there can be defects in the collagen and elastic connective tissue. So congenital weakness of the cervical tissue, that can be one reason. Or there can be acquired causes of the cervical incompetence. Like for example, there has been a prior cervical procedure that has been done where the cervix has been, let's say, amputated. Like for example, conization. Now conization is a procedure that is done for management of cervical intraepithelial neoplasia. So in that we remove a cone of cervical tissue. So maybe there is a history of conization. Keep that in mind. That is an important pointer. Okay, this history of conization. So maybe a procedure like that has been done in the past, which is responsible for cervical incompetence. Then there will be this classical history of painless cervical dilatation, because the cervix just simply dilates. Okay, and there is no uterine contractions. Okay, normally what happens is first uterine contraction sets in, then cervix dilates, and then delivery takes place, right? Here opposite will happen. There will be painless cervical dilatation followed by just sudden expulsion of the fetus. Okay, now how do we make the diagnosis? The diagnosis is made first of all by classical history. Okay, history is very, very important in making the diagnosis of cervical incompetence. This history will be there. Okay, and let's say for example, if we have to make diagnosis in the non-pregnant state. Okay, so there is a history of prior abortions and right now the woman is not pregnant. Then in that situation, easy passage of Hagar's number 8 dilator, okay, through the cervix. Easy passage of number 8 Hagar dilator through the cervix. That can be done, but it's something that we generally don't do because it's very non-specific. It's a very non-specific kind of a test. Okay, so yes, in textbooks it is written, for MCQs also it is important, but it's something that we generally don't do. Non-pregnant state, easy passage of Hagar's number 8 dilator through the cervix, that could point towards cervical incompetence. It's not certain of cervical incompetence. In the pregnant female, many times we will be in this situation. Many times, most of the times we will be in this situation. Very good, STVS, very good, that there will be a history of recurrent pregnancy losses, classical history of cervical incompetence, and she's already pregnant. Then you can't introduce any instruments inside. Then your diagnosis is based on transvaginal sonography. What do we see on transvaginal sonography? Cervical length less than 25 mm before 24 weeks of gestation. Before 24 weeks of gestation. That is what we see. This is most important, the cervical length. Okay, so we see this on ultrasound. Okay, so let's say this is the cervix and this is the cervical length. Okay, this is what we are measuring. Okay, there can be other findings also. Let's say funneling of the os. Okay, let's say funneling of the os. That means the internal os has started to open up. Funneling of the internal os. This is also one finding that you may have heard about. Okay, but just funneling alone, not important. It is the length of the cervix. It is the length of the cervix that is most important. Keep that in mind. Okay, so how do we make the diagnosis? Cervical length less than 25 mm. That's an important number to remember. And what is the treatment of cervical incompetence? The treatment of cervical incompetence is cervical cerclage procedure. Cervical cerclage procedure, and the most commonly done procedure is McDonald's cervical cerclage. McDonald's cervical cerclage procedure. Okay, McDonald's cervical cerclage procedure, and this is done by the vaginal route. This is done by the vaginal route. Okay, so in the vaginal route, what do we do? Like for example, this is the cervix. Okay, and we are going to take sutures, first string sutures, all around the cervix, and then we are going to tie it in front, like purse string sutures. Okay, and tighten it. So that is the treatment. That process is called as cervical cerclage. Now coming on to the next question. Ultrasound is done in the first trimester for all of the following reasons except ultrasound is done in first trimester for all of the following except. So ultrasound in the first trimester can help us diagnose multiple pregnancy. Yes. Ultrasound in first trimester can help us for gestational age estimation. Yes. Ultrasound in first trimester can help us in aneuploidy screening. Yes, also. Right? But for fetal anomalies, for detection of fetal anomalies, we go for level 2 ultrasound, and that is done between 18 to 20 weeks. Okay, so if I have to do ultrasound for fetal anomaly detection, the best time is between 18 to 20 weeks. So that is the answer here. Okay, so ultrasound done in first trimester for all of the following except detection of fetal anomalies. Okay, so the routine ultrasound for fetal anomaly detection that we do is done between 18 to 20 weeks of gestation. So very good, Shivam, you answered that correctly. So let's just have a look at ultrasound for gestational age estimation. That's a very, very important MCQ pointer. Okay, so ultrasound for gestational age estimation. What are we measuring here? Can you see here? We are measuring the, see, from the top of the baby's head, that's the crown, to the bottom, that is the rump. So this is what we are measuring, and this is what we call as the crown rump length. We are measuring the crown rump length. Okay, now Shivam, what is level 1 and what is level 2? Level 1 is simply just a routine ultrasound in pregnancy where the sonologist is not commenting on whether there are any congenital anomalies in the fetus or not. Okay, so level 2 is basically when the ultrasonologist examines the fetus and tells us whether there is any congenital anomaly in the fetus or not. So that's the difference. So we are checking the crown rump length, and this is the best for gestational age estimation, right? So overall best for gestational age estimation is first trimester crown rump length measurement. crown rump length measurement. Okay, so remember that. In the second trimester, if we have to use ultrasound for gestational age estimation, then crown rump length we no longer measure. We measure the biparietal diameter. We measure the biparietal diameter. Okay. In the third trimester, we measure the femur length. We rely on the measurement of femur length. Okay. So these are basically MCQ pointers, but you also have to remember that when we perform an ultrasound, if you've ever read an ultrasound report, okay, the ultrasound person will measure the biparietal diameter, will say that the biparietal diameter measures this many millimeters, that corresponds to, let's say, this many weeks. Then he will measure the femur length also, he will measure the abdominal circumference also, head circumference also, right? So when we are going to go for an ultrasound, the sonologist measures every parameter: biparietal diameter, femur length, head circumference, abdominal circumference, and then he gives a composite estimation. He gives a composite estimation of the gestational age also, and a composite estimation of the estimated fetal weight also. Composite estimation of the estimated fetal weight also. Okay, now there are inbuilt formulas in the ultrasound machine. Okay, you just need to know the names of these formulas. So for estimation of fetal weight, there are inbuilt formulas like the Hadlock formula. There is a Shepherd's formula. Okay. You don't need to know what these formulas are typically, just remembering the name is good enough. Okay, so composite estimation of gestational age is arrived at, or a composite estimation of fetal weight is arrived at. But if they ask you specifically which parameter corresponds to gestational age assessment in second trimester, then biparietal diameter is the answer if you have to choose one. In third trimester, it is femur length. And as you were asking about abdominal circumference, abdominal circumference, note down, abdominal circumference, note down, is not for gestational age estimation. It reflects the growth of the fetus. It reflects the growth of the fetus. Okay, so if the abdominal circumference is less, that means fetal growth restriction. If the abdominal circumference is more, it reflects fetal overgrowth, that is macrosomia, right? So that is an important point to note. Now, next important point, next important image, again for MCQs, they're asking you a lot of questions on ultrasound estimations. Okay, and these are all previous year MCQs. So what do we see in this image? Have a look. We see the uterus. Okay, in this image we are seeing the uterus. This is the outline of the uterus. This is a gestational sac. Okay, this is a gestational sac. Inside a gestational sac, we see another small sac. Okay, and we see some fetal pole. Okay, this here that we are seeing, okay, this here that we are seeing is the fetal pole. If this were a live ultrasound, we would be able to see the heart beating also, the cardiac activity also. Okay, this is the endometrial lining. This is the endometrial lining here. Okay, and we can see two white lines around the gestational sac. Can you see? These are two white lines around the gestational sac. Okay, so this is what we call as the double decidual sac sign. This is what we call as a double decidual sac sign. So the image again is important. So first of all, the gestational sac is going to come. Okay, as the fetus is going to develop, then the embryo will be seen inside, and the last thing that will be seen is the cardiac activity. So they ask you, gestational sac is seen earliest by what time? So gestational sac is seen earliest by 4 weeks, 1 to 3 days on transvaginal sonography, earliest by, and on transabdominal sonography, earliest by 5 weeks. Okay, cardiac activity is seen earliest by 5 to 6 weeks on transvaginal sonography and 6 to 7 weeks on transabdominal sonography. Keep that in mind. If they ask you to choose one number, choose the lower number. Okay, if they ask you to choose one number, choose the lowest number, that is earliest seen. Okay, earliest seen. If they don't specify on the type of ultrasound, if they just ask you that gestational sac is seen earliest by what gestational age on ultrasound, and they are not telling whether they are asking about transvaginal sonography or they're asking about transabdominal sonography, then you choose according to the transabdominal sonography value. Keep that in mind also. So you can make it a pointer here that if they are not specifying the type of ultrasound, if they are not specifying the type of ultrasound, then you choose your answer according to the transabdominal scan value. Okay, now if they ask you the question, what is the earliest sign of intrauterine pregnancy on ultrasound, what's your answer? Earliest sign of intrauterine pregnancy on ultrasound. Yes, anybody? Earliest sign of intrauterine pregnancy on ultrasound. Earliest sign will be a gestational sac. Which gestational sac? A gestational sac which has a double decidual sac sign. So have a look at this image. This will help you remember. This image here is showing you the gestational sac. Okay, this image here is showing you the gestational sac. So yes, intradecidual sign, you're right in that also, but it has to be very specifically answered. Okay, so gestational sac, you can see here, this here is the decidua basalis. Okay, this here blue line is the decidua capsularis, and the yellow line is the decidua parietalis. Okay, so what we are seeing here now, you can superimpose. Okay, what we are seeing here is the decidua capsularis and the decidua parietalis. These two, decidua capsularis and decidua parietalis, these two are seen as concentric white lines, okay, around the gestational sac. Now this is called as the double decidual sac sign. So if they ask you earliest sign of intrauterine pregnancy on ultrasound, then your answer should be, look in the option if they are saying double decidual sac sign. Double decidual sac sign. Okay, then that's your best choice answer. If that's not in the option, then you can pick gestational sac as the option. Okay, keep that in mind. And then you have what is the earliest definitive sign. Definitive sign of intrauterine pregnancy on ultrasound. That means it is nothing but a pregnancy. It cannot be anything other than a pregnancy. That is what they're saying. That means that there is a yolk sac now inside the chorionic cavity. So once there is another white circle inside the gestational sac, another white circle inside the gestational sac here, then it is called as the double bleb sign. So earliest definitive sign of intrauterine pregnancy on ultrasound, your answer should be double bleb sign. Double bleb sign. Okay, and this was an MCQ also in your FMG examination. They had asked, what does this sign mean? This sign means there is a yolk sac inside the chorionic cavity. Inside the chorionic cavity. Okay, so keep that in mind. All right, now the other indication in the question was aneuploidy screening. So for aneuploidy screening in the first trimester, the ultrasound parameter that is used is nuchal translucency. Image identification important. So in this image you can see here, this is the NT that is being measured, nuchal translucency, right? Now this is just fluid collection behind the nape of the neck of the fetus. So this is called as nuchal translucency, right? So this is a first trimester marker. Remember that it is done anytime between 11 to 14 weeks of pregnancy, 11 to 14 weeks. So that's an important MCQ pointer. An NT that is more than or equal to 3 mm, that is abnormal. Okay, an NT that is more than or equal to 3 mm, that is abnormal. And if there is raised nuchal translucency, there is increased risk of Down syndrome in the fetus. Okay, there is risk of monosomy X also, and there is also increased risk of other congenital malformations in the fetus, particularly fetal cardiac malformations. Okay, and other gross congenital anomalies can also be there, but most particularly fetal cardiac malformation. So this is important to remember. So nuchal translucency only tells you that there is an increased risk. It doesn't confirm anything. Okay, so a raised nuchal translucency is a marker for these underlying abnormalities which could be there in the fetus. So let's quickly revise the screening test for aneuploidy also, right? So we can have the first trimester combined screening. Now this first trimester combined screening, again, it is done between 11 to 13 weeks, 6 days. 11 to 13 weeks, 6 days, anytime between that time, first trimester combined screening can be done. Combined meaning that we are doing nuchal translucency. NT is seen on transvaginal sonography. So NT is seen on transvaginal sonography. And then there are serum markers. Serum markers that we are going to do is PAP-A and beta HCG. Okay, PAP-A and beta HCG, these are serum markers. Okay, these are serum markers. So maternal blood sample is tested. Then we have triple test and quadruple test. Both these tests can be done anytime between 15 to 20 weeks of gestation. So they are done in the second trimester. Okay, now what are the markers? Very, very important to remember. Triple test has almost become obsolete. We are not doing triple test anymore. Mostly if we have to do in the second trimester any screening test, we go for quadruple test. It contains beta HCG, maternal serum, alpha fetoprotein, unconjugated estriol, and inhibin A. Okay, fine. If only these three are done, then it is the triple test. All right, so these are the markers for quadruple test that are done. Then there is an integrated test where in the same woman we first go for the first trimester combined screening. Then when she reaches the second trimester, we do go for the quadruple test, and after that we assess a combined risk, whether there is a risk for Down syndrome fetus or not. Okay, so these are the screening test, and the latest screening test which you need to remember is the NIPT. Very, very important, NIPT. Okay, potential question. So NIPT is non-invasive prenatal testing. Non-invasive prenatal testing. In this we take the maternal blood sample. Okay, in this we take the maternal blood sample, and in this maternal blood sample we can check for the cell-free fetal DNA. Okay, this is also called as cell-free fetal DNA testing. Okay, fetal DNA that is freely circulating inside the maternal bloodstream. So that is cell-free fetal DNA testing. Currently it is available for trisomy 21, trisomy 18, 13 and monosomy X. Okay, the limitation of this NIPT is that it is very expensive. Okay, it is very expensive. That is the limitation why it is not being used very often. And secondly, the other important limitation is that it is just a screening test. Okay, it is not a confirmatory test, it is screening test only. Any screening test, if positive, has to be confirmed by invasive fetal testing. Okay, keep that in mind also. And whenever there is any screen positive, first trimester combined screen positive, or a quadruple test positive, or an NIPT test positive, so whenever any of these screening tests are positive, confirmation has to be done by invasive fetal testing. Okay, in invasive fetal testing, what do? We take fetal sample, fetal tissue sample. and then we subject the fetal tissue to karyotyping, right? So on this we are going to go for karyotyping. Okay, and karyotype will tell us whether it is trisomy 21 or not. Okay, so what are the methods of invasive fetal testing? Now, as whether we go for amniocentesis or, okay, wait, Fatehpuria brothers, if they ask which one can do in second trimester and both are option, why will they give you both are option? Okay, triple test can also be done in second trimester, quadruple test can also be done in second trimester. We are generally doing quadruple test for this purpose. NIPT on the other hand can be done anytime beyond 10 weeks of gestation. Anytime beyond 10 weeks of gestation, NIPT can be done. Right now, as you are talking about, you said amniocentesis will be done. Okay, now which confirmatory test will be done will also depend upon which screening test came positive. Now, I mean, when do you have the positive result? Like, for example, if a woman has first trimester combined screening positive, okay, first trimester screening result came before 14 weeks. All right, at that point in time, I can't do amniocentesis. So I will do chorionic villus sampling instead. Okay, let's say if she has come with a positive report of quadruple test, then at that point in time, she is beyond 15 weeks. So I will not be able to do chorionic villus sampling, then I will do amniocentesis. Right, so what test, what invasive fetal testing you will do will depend upon when is she having the positive screening result. Okay, so very important, image based identification of these invasive fetal testing procedures also. So in this image you can see here a catheter, a very thin catheter is introduced through the cervix, all right, and the chorionic villi, you can see here the catheter is being introduced along the placenta, towards the placenta. So chorionic villi are sampled. This is chorionic villus sampling. Then in this image, you can see that a needle is introduced from the abdomen, and these are all ultrasound guided procedures. All procedures are done under ultrasound guidance. This is ultrasound probe. Okay, all these procedures are done under ultrasound guidance. And in this image, you can see that the needle is introduced into the amniotic cavity and amniotic fluid is sampled. So this is amniotic fluid that will be sampled. Okay, and then on the other side, you can see here, compare, you can see that the needle is being introduced into the umbilical cord. Okay, so this is chordocentesis. This procedure is chordocentesis. PUBS stands for percutaneous umbilical blood sampling. Umbilical blood sampling. Okay, so what are we sampling? In the umbilical cord, we are sampling the umbilical vein. Remember that we are sampling the umbilical vein. Okay, so the umbilical vein is sampled, not the umbilical artery that is sampled. So, timing of these procedures, look at this chart. Chorionic villus sampling can be done anytime between 10 to 14 weeks. Okay, I can't do it before 10 weeks. I can't do it beyond 14 weeks. Okay, so this is the timing in which we can do this procedure. Amniocentesis can be done again between 15 to 20 weeks. If required, it can be done beyond 20 weeks also. If required, can be done beyond 20 weeks also, but generally it is done between 15 to 20 weeks. But please remember, it will not be done before 15 weeks. Amniocentesis, chordocentesis can be done anytime beyond 18 weeks onwards, right? So now look at this, the sample that is taken with chorionic villus sampling. The sample that is taken is the trophoblast cells. Amniocentesis, we are sampling the amniotic fluid. Inside the amniotic fluid are suspended fetal cells. Suspended fetal cells which can be extracted. These suspended fetal cells are amniocytes, fetal epithelial cells, fetal gastrointestinal mucosal cells. Now these cells can be cultured and then they can be used for karyotyping. And in chordocentesis, we are sampling the fetal blood. In the fetal blood, there are WBCs also. These WBCs can then be used for karyotyping and genetic analysis, right? So all of these invasive fetal tests, what are they doing principally? Principally, we are getting fetal tissue, and that fetal tissue can then be analyzed for the diagnosis of genetic disorders, chromosomal abnormalities, even fetal infections. So Diagnosis of genetic disorders, chromosomal abnormalities, fetal infections is possible by any of these three methods. Okay. Now, what about fetal anemia? Amniocentesis can detect fetal anemia. Can detect fetal anemia because when there is going to be fetal hemolysis, okay, like for example in Rh affected pregnancies, when there is going to be fetal hemolysis, then bilirubin will come in the amniotic fluid. So fetal anemia can be detected. Okay, but amniocentesis is not the first line test to use for that indication. Amniocentesis can also detect neural tube defects. Okay, in neural tube defects, there is going to be raised levels of alpha fetoprotein. These raised alpha fetoprotein levels can be detected in the amniotic fluid as well. So neural tube defects can also be diagnosed by amniocentesis, but amniocentesis, let me highlight it again and again, it is not going to be used as a first line for detection of fetal anemia or neural tube defects. It is possible to detect fetal anemia and neural tube defects by amniocentesis. Okay. Chorionic villus sampling on the other hand, chorionic villus sampling on the other hand, chorionic villi, we are sampling the trophoblast. It will tell us nothing about fetal anemia. It cannot be used to diagnose neural tube defects also. Chordosynthesis on the other hand, if we are sampling fetal blood, we can definitely confirm fetal anemia. We can definitely confirm fetal anemia. Okay. All right. And neural tube defects? No, we can't detect neural tube defects on chordosynthesis. All right. Keep that in mind. And also highlight one more pointer here. I told you that for fetal anemia detection, amniocentesis can be used. I told you it is not being used. So what is being used? So write down your question pointer. Nowadays, for early detection of fetal anemia, in Rh affected fetus, is done by middle cerebral artery Doppler. Which is ultrasound Doppler. Okay, so this is being used, which is non-invasive. Okay, it's done on ultrasound. Ultrasound middle cerebral artery Doppler is going to be used. Keep that in mind. This is for early detection of fetal anemia in Rh affected fetus. All right. Now, important pointers about neural tube defects. Now, you'll understand why, chorionic villus sampling or you'll understand why these invasive fetal tests are not needed for neural tube defects diagnosis, because have a look at this. Neural tube defects are structural malformations. Okay, like there is probably a spina bifida, as you can see in this image. There may be a spina bifida. You all know this from your embryology lectures. Okay, this here is showing anencephaly. This here is showing anencephaly in the fetus. Okay, this here is showing encephalocele, or there could be a meningocele or a meningomyelocele, right? So these are structural malformations and they are picked up with ultrasound. Very, very easily. Okay, keep that in mind. So in current practice, they are diagnosed by ultrasound. Okay, and if there is any suspicion of neural tube defects, we ask the sonologist to do a targeted sonography. Okay, we ask the sonologist to do a targeted sonography. That is what it is called as. Okay, so keep that in mind. Diagnosis is made by ultrasound. Non-invasive will pick up so many neural tube defects. We don't need to go for amniocentesis to diagnose them. Okay. Other important point, neural tube defects, they are associated with deficiency of, very, very important MCQ pointer, neural tube defects are associated with deficiency of folic acid. Okay, deficiency of folic acid in the mother. Okay, but multifactorial, neural tube defects are multifactorial. Deficiency of folic acid is only one possible explanation. Okay, then remember these 3 Ds. Okay, deficiency, drugs and diabetes. So the drugs that I want you to remember are most importantly anti-epileptic drugs. If a woman is on anti-epileptic drugs, then there is increased risk of neural tube defects in the fetus and maternal diabetes as well. Now, neural tube defects, they are also associated with raised levels of maternal serum alpha fetoprotein. Maternal serum alpha fetoprotein. Okay. So, maternal serum alpha fetoprotein levels, if they are raised, then diagnosis will be made by targeted sonography or ultrasound only. So, that is how neural tube defects are diagnosed. Then they ask you, what can we do for prevention of neural tube defects? For prevention of neural tube defects, we advise the woman to take periconceptional folic acid. Periconceptional folic acid. Periconceptional folic acid meaning that ideally it should be given 1 month prior to conception. Ideally 1 month prior to conception. Right? And then she is going to continue till first trimester is over. Okay, 1 month prior to conception, given through and through the first trimester. Right, so that is what we are going to give for prevention of neural tube defects. Then they ask you, what is the recommended dose? The recommended dose is 400 microgram per day. 400 microgram per day. But if there is a history of prior affected fetus, or if the woman is on anti-epileptic drugs, then the dose is different. Then the recommended dose is 4 milligram per day. Then higher dose is recommended. Keep that in mind. Okay, yes, in neural tube defects, chromosomal abnormalities नहीं हो सकती हैं. Generally, we say chromosomal abnormalities are not there in overt diabetes. We say chromosomal abnormalities are present in overt diabetes. If the woman has overt diabetes, the chances of congenital anomalies in the fetus are increased. Okay, neural tube defects is a structural abnormality. Okay, there is structural development of the fetus is the problem. It is not associated with underlying genetic chromosomal abnormality. Okay, fine. All right, and it's not absolute. Many of these gross congenital anomalies, like for example, gross congenital anomalies like, fetal cardiac disorders, brain malformations, renal disorders, they are associated. All these gross congenital anomalies, they could also be associated with underlying chromosomal abnormality in the fetus as well. So when we have a gross congenital anomaly, then the chances of finding a chromosomally abnormal fetus are also increased. But with neural tube defects, these are typically structural malformations. Okay. Now, two important pointers about anencephaly. Very, very important pointers regarding anencephaly. Look at this image of anencephaly. There is a fetus. Okay, look at this image of anencephaly fetus. There is a fetus with only the face. Okay, the skull and the cerebrum and the forebrain structures, they are all missing. Okay, so this is not there. The skull and the forebrain structures are not there. Only the face is there. Keep that image, important image in mind. Now, this is one congenital anomaly. This is one congenital anomaly that can be diagnosed by first trimester ultrasound also. That's why it is an important MCQ pointer. What did I tell you? That for the diagnosis of congenital anomalies, when are we doing the scan? We are doing second trimester anomaly scan. But if there is one anomaly that can be picked up, on a first trimester ultrasound, that is anencephaly. It can be diagnosed earliest by 10 weeks and definitely by 14 weeks. And remember two important ultrasound signs for MCQ purposes. Okay, so the two important signs are frog eye sign and Mickey Mouse sign. Frog eye sign, Mickey Mouse sign. So when this face is seen on ultrasound, the orbits, okay, the eyes, the protruding eyes are seen. It looks like the eyes of the frog. That's why frog eye sign. And again, looks like the mouth, the face of a Mickey Mouse. So Mickey Mouse sign. All right. So they can be picked up on ultrasound by the help of these signs. Now let's have a look at the next question. Ectopic pregnancy means pregnancy outside the uterus. Okay, which ectopic pregnancy can present with painless vaginal bleeding? MCQ from your FMG examination. Which ectopic can present with painless vaginal bleeding? So if the ectopic is in the cervix, if it is a cervical ectopic, which is rare, which by itself is rare, okay, then the location of the ectopic is such that it will present with vaginal bleeding, okay, and you see there is nothing inside the uterus, okay, there's nothing inside the uterus, so it's not like the uterus is contracting. Mainly in case of abortions, the uterus contractions are the reason for the lower abdominal pain. Okay, when the pregnancy is inside the cervix, it can lead to painless vaginal bleeding also. Okay, in fact, this is very typical of cervical ectopic, but let me also tell you, it is a very rare kind of an ectopic, that is cervical ectopic. So let's have a look at these locations of the ectopic pregnancy. So you can see here, these are the various parts of the fallopian tube. So you can have a ectopic in the ampulla. This is the ampullary ectopic. Okay, you can have it in the infundibulum. So this is infundibular. Okay, you can have it in the isthmus. So this is isthmic ectopic pregnancy. You can have it in the interstitium. So this is interstitial ectopic. This is the interstitial part of the fallopian tube, interstitial ectopic. There can be very rare Caesarean section scar ectopic. Caesarean section scar ectopic, again very rare cervical ectopic. Okay, right? Then we can have ectopic in the ovaries. Okay, so that would be an ovarian ectopic. And then we can have ectopic in the abdomen also, anywhere in the abdomen, again very rare, but it can be anywhere in the abdomen. It can be on the omentum, it can be on the gut, on the wall of the gut, basically, not inside, sorry, okay, not inside not inside the gut or anything, but on the wall of the gut, anywhere in the pelvis, it can be there. Then that is called as an abdominal ectopic. Okay, so when you have these different locations on ectopic, they ask you what is overall the most common site of ectopic. So overall the most common site of ectopic is tubal ectopic among all the sites of ectopic. Okay, and among the tubal ectopics also, most common is ampullary ectopic, if that's in the option. Second most common is isthmic. Second most common is isthmic. Okay, then they ask you what is the most common consequence of a tubal ectopic. Now let's just have a look at this tubal ectopic as well. Okay, so most common, I'm saying, that is this one here, ampullary ectopic. Okay, now this tube is not a right location for a pregnancy, of course, isn't it? The tube is very thin also, and the tubal lining, okay, the epithelium of the tubal lining also does not have a submucosa layer. So what happens is that the pregnancy keeps on burrowing, the sac keeps on burrowing into the tubal epithelium, and that causes, you know, stretching of the fallopian tube. This stretching of the fallopian tube causes pain. Okay, this stretching causes pain. All right, then what will happen is that again this ectopic here is not going to get, or this pregnancy here is not going to get enough blood supply, okay, like it would get in the uterus from the endometrium. But here there will not be any good vascularity for the gestational sac to grow. So most likely consequence of an ectopic pregnancy is what is called as tubal abortion. Okay, the tubal abortion will take place. That means this sac will just die out. Okay, the sac will just die out, and then this sac could get expelled from the fimbrial end into the peritoneal cavity. But then when that will happen, there is obviously going to be some bleeding. Obviously there is going to be some bleeding. Okay, now that depends upon how much the bleeding happened. If the bleeding is excessive, then the woman will go into shock. If the bleeding is mild, then she may be stable as well, right? And then yes, of course, rupture of the fallopian tube can also take place, right? So when they ask you, what is the most common consequence of tubal ectopic, if there is tubal abortion is in the option, then that's your answer, tubal abortion. Okay, and this happens because of, this tubal abortion happens due to vascular insufficiency, vascular insufficiency of the embryo. That's another important MCQ pointer you need to keep in mind. Now in tube, widest part is ampulla, longest part is also ampulla. Yes, Fatehpuria, yes. Widest part ampulla, longest part also ampulla. Then they ask you earliest to rupture among tubal ectopic. So the earliest to rupture is the isthmic ectopic. The isthmic ectopic ruptures at around 6 weeks of gestation, right? The ampullary ectopic ruptures somewhere around 8 weeks of gestation. It can rupture earlier also. There is no hard and fast rule. Generally, ampullary ectopic ruptures at around 8 weeks. Isthmic is the earliest to rupture. Very, very important MCQ pointer. Last to rupture among tubal ectopics, and somebody had already answered that. That was S, interstitial. Last to rupture among tubal ectopics is the interstitial ectopic. Interstitial ectopic. Okay, why interstitial ectopic is the last to rupture? If you have a look at this diagram here, the interstitial portion of the fallopian tube is traveling through the uterine cornu. So there is uterine muscle around it. So there is some protection against rupture there, because surrounding uterine muscles are there. Okay, so interstitial ectopics are the last to rupture, somewhere around, they can even go till around 10 to 12 weeks of gestation. But when they rupture, interstitial ectopics are the most dangerous. Why? Because the uterine muscle must have also ruptured. So now there is this massive source of bleeding which will become very hard to control. Okay, so there is, the bleeding will not just happen from the branches of the uterine arteries, but also from the branches of the ovarian arteries that are supplying the tube. So interstitial ectopics, when rupture, they bleed more. The bleeding is also more difficult to control during surgery, right? So that is another MCQ pointer right there, that most dangerous if ruptures is again the interstitial ectopic. Keep that in mind. Okay, fine. So to clarify once again, ampulla is the widest, longest part of the fallopian tube. Ampulla is the site for fertilization. Ampulla is the site that is most common site for ectopic pregnancy also, right? Fine. Then you have the isthmic ectopic, which is the second most common site of ectopic. Earliest to rupture among tubal ectopics, isthmic ectopic, right? Interstitial ectopic is the last to rupture among tubal ectopics. When it ruptures, it is the most dangerous also. And please, yes, do not get confused. Interstitial part of the fallopian tube is actually anatomically the narrowest part of the fallopian tube. Interstitial part of the fallopian tube is actually anatomically the narrowest part of the fallopian tube. Isthmus is the second narrowest part. Even then, don't get confused. Interstitial is the last to rupture among tubal ectopics because of the protection given by the muscle fibers of the uterus. All right, so keep that important distinction in mind. All right, and then finally, what is an angular pregnancy? Now these are again also important for MCQ pointers. What is an angular pregnancy? An angular pregnancy is an intrauterine pregnancy. It's not an ectopic pregnancy. It is a intrauterine pregnancy that is implanted at the angle of the uterine cavity. It is a intrauterine pregnancy, just that it is implanted at one corner. Okay, what is a cornual pregnancy? A cornual pregnancy is a pregnancy in the rudimentary horn, of a unicornuate uterus. Okay, that is called as cornual pregnancy. Keep that in mind. Interstitial pregnancy is not the same as cornual pregnancy. Okay, interstitial pregnancy is often called as cornual pregnancy, but they are not the same. Cornual pregnancy specifically is pregnancy in the rudimentary horn of a unicornuate uterus. What is a heterotopic pregnancy? Heterotopic pregnancy is a very rare type of ectopic pregnancy, which is one inside the uterus and one ectopic. And this one ectopic is again most commonly tubal. Most commonly tubal. That is a heterotopic pregnancy. At the same time, there is one pregnancy inside the uterus. At the same time, there is another pregnancy outside the uterus. And most commonly, that is ectopic. This is heterotopic pregnancy. It is very, very rare, but nowadays with increasing IVF cases, okay, we are doing IVF now more often, so the incidence is more in IVF pregnancy. So we are seeing now cases of heterotopic pregnancy also, right? So these are important one-liner pointers. Keep them in mind. And then what is the most common risk factor for tubal ectopic? Another important MCQ pointer. The most common risk factor for tubal ectopic, if they ask you, is tubal damage. Tubal damage because of what? Tubal damage because of pelvic inflammatory disease. PID is the most common risk factor because so many women have PID, isn't it? But if they ask you maximum risk of ectopic pregnancy, then see, if there is one woman with PID, one woman who has a prior history of ectopic pregnancy, there is another woman, let's say she has some tubal surgery that has been done in the past, then which among these three is at most risk of having an ectopic pregnancy? The one who has had a prior ectopic pregnancy. So if they ask you maximum risk of ectopic pregnancy, then the answer is different. Maximum risk of ectopic pregnancy, answer is prior history of ectopic pregnancy. Prior history of ectopic pregnancy, first choice answer. If that is not in the option, then any prior history of tubal surgeries. Any prior history of tubal surgeries. Okay, and very good. S, TB, yes. So PID in general, and yes, genital tuberculosis also will be included in this PID only. Okay, genital tuberculosis will also be included in this PID only, because essentially what genital tuberculosis is doing is fallopian tube involvement and damage to the fallopian tube. It's essentially causing pelvic inflammatory disease only, right? So maximum risk of ectopic pregnancy is the answers I have told you. Okay, and somebody had mentioned something and I'm forgetting. OCP, somebody had mentioned OCP. I don't know. Right, so as you had mentioned OCP. So all contraceptives, please remember, they actually decrease the absolute risk of ectopic pregnancy. Absolute risk of ectopic pregnancy. Okay, because contraceptives, they prevent pregnancy. Okay, so because they prevent pregnancy so well, the absolute risk of ectopic pregnancy is actually decreased. But when a woman is on some contraceptive method and she conceives while on that method, that means failure of contraception. When there is failure of contraception, then of course the risk of ectopic pregnancy increases. Risk of ectopic pregnancy increases. Okay, so that is an important pointer to note. Okay, in the MCQs questions, the options could be like that. Okay, just a contraception or failure of contraception. Remember, failure of contraception increases the risk of ectopic pregnancy, not contraception in general. Keep that in mind. And then another pointer is failure of which contraception. You said OCPs. Failure of OCPs, least risk of ectopic pregnancy, right? So failure of which contraceptive method? Failure of tubal sterilization. Then Mirena, and then Copperty. Okay, then progesterone only methods, and then OCPs. Okay, keep that in mind also. Okay, So yes, Shivam, these two, both of these two are intrauterine devices. Both of these two are intrauterine devices. Mirena is Levonar gestral releasing intrauterine device. Copper T is copper releasing intrauterine device. Both are intrauterine devices. Okay, fine. Now, next question. An 18-year-old unmarried girl presented with the complaint of 2-month amenorrhea and a fainting episode. Her physical examination is otherwise normal and vitals are stable. What should you do next? What should you do next? She's an 18-year-old unmarried girl. Basically, she's in the reproductive age group. Whether married, whether unmarried, whether she says she's sexually active, whether she says she's not sexually active, whatever. Reproductive age group woman, amenorrhea, always think about pregnancy first. Always rule out pregnancy. Very, very important point. Okay, keep that in mind. All right. Yes, of course, this is a previous year question. Even though her physical examination is normal right now, her vitals are stable right now, but what should you do next? You should do a urine pregnancy test. All right, keep that in mind. That is very, very important. She may be having some abortion related complications. She may be having some ectopic related complication, right? So UPT is very, very important here in this situation. Okay, any reproductive age group female, amenorrhea, she could have amenorrhea with pain, she could have amenorrhea with bleeding, she could have amenorrhea with pain and bleeding, whatever. Do a urine pregnancy test. Think of possibility of pregnancy related complication. All right, so bleeding and pain in early pregnancy. The moment you see a situation where there is a period of amenorrhea mentioned and there is bleeding plus minus pain, whatever be the symptom triad, okay, think about abortion, think about tubal ectopic. So in abortion cases, what will happen? Bleeding usually happens first. Bleeding usually happens first, followed by lower abdominal pain, and the uterus would be enlarged because the pregnancy is inside the uterus, isn't it? The uterus would be enlarged. In a tubal ectopic, however, what will happen? Your pain will be the predominant complaint. Okay, pain will be the predominant complaint. She may or may not have bleeding, plus minus bleeding. She may or may not have bleeding. Okay. Now, Shivam, I'll come back to your question a little later. Let's just take this in the flow. So pain is going to be the predominant complaint, plus minus bleeding. Uterus would be normal size because the pregnancy is not inside the uterus. So uterus would be given as normal size. And then you may have a finding of a tender adnexal mass given to you. There may be cervical motion tenderness. There may be cervical motion tenderness also mentioned in the question. Abortion I will take up in the next question. Abortion I will take up in the next question. Let's focus on ectopic. So ectopic, pain becomes the predominant complaint. Uterus will be given to you as normal size because pregnancy is not inside the uterus. There may be an adnexal mass finding given to you, which is going to be tender. Some cervical motion tenderness is going to be there. All right. When you will do an ultrasound, the first thing that you're going to notice is that there is an empty uterus. Okay. We may find a gestational sac with cardiac activity in the region of adnexa. This is going to be most confirmative. Obviously, now if we see a gestational sac with cardiac activity in the region of adnexa, that's obvious that it's a tubal ectopic pregnancy, but that's not the most common finding, unfortunately. Unfortunately, this finding, which is very good but less commonly seen, most common finding is that of a complex adnexal mass. This is the most common finding on ultrasound. There will be certain additional signs. You should just know the names of these signs. Know the names of these signs. Bagel sign. Bagel sign is also called as the donut sign. Donut sign. Okay, so let's say if this is the uterus, then around in the adnexal region there is this mass that is seen like a donut. Okay, so that is bagel sign. Sometimes there's just a blob of a mass. Okay, that is called as a blob sign. And sometimes there is this all this vascularity around the mass, that is called as tubal ring of fire sign. So know the names of these signs. These signs are associated with ectopic pregnancy. Yes, the break is going to be just after this question. Okay, break is going to be just After this question, we're going to give the break. All right. So now coming back, the diagnosis of an ectopic pregnancy. Now I've written the findings in front of you. All right. So how did we start? We started with a woman with a pregnancy that has been confirmed on urine pregnancy test. So we started with amenorrhea. We started with urine pregnancy test positive, and we started with symptoms of pain plus minus bleeding. We started with examination findings, then we did an ultrasound. All right, this ultrasound is preferably a transvaginal sonography. So this ultrasound is our investigation of choice because it will help us look for findings suggestive of ectopic pregnancy. This ultrasound will help us to see if she has an abortion, because in abortion cases the pregnancy will be inside the uterus. So investigation of choice to begin with is an ultrasound, and we analyze the entire clinical picture like this to come to a diagnosis of ectopic pregnancy. Right now, if in this situation you happen to have a situation where the woman is going in shock, right, that means she is bleeding. Where? With an ectopic pregnancy, where will she bleed? Inside the peritoneal cavity. Blood will collect inside the peritoneal cavity now, because this tube will be ruptured or there will be this tubal abortion. So blood will collect inside the pelvis. So there is not going to be visible bleeding. Right? So what will your findings be? Your findings will be that of generalized pain abdomen. Generalized pain abdomen. Your findings will that be of abdominal distension. Okay, guarding tenderness rigidity. Okay, yeah, POD, yes, we'll see the POD also, but go step by step. Pain, then abdominal distension will be there. Guarding tenderness, rigidity could be there. This is because of hemoperitoneum. Right? Guarding tenderness and rigidity because of hemoperitoneum. Okay, and what else will be there? There can be signs suggestive of massive intraperitoneal hemorrhage. Signs suggestive of massive intraperitoneal hemorrhage. Massive intraperitoneal hemorrhage. Massive intraperitoneal hemorrhage. हाँ शिवम, rebound tenderness भी हो सकता है. Yes, rebound tenderness भी हो सकता है. Tenderness, rebound tenderness, that's also fine. Cervical motion tenderness can happen in an unruptured ectopic also. Cervical motion tenderness can happen in unruptured ectopic as well as ruptured ectopic. Okay, not very specific, can happen in both. Signs suggestive of massive intraperitoneal hemorrhage: bluish discoloration around umbilicus, Cullen sign. Bluish discoloration around umbilicus. Bluish discoloration around umbilicus. Turner sign. Bluish discoloration around the flanks. Bluish discoloration around the flanks, that is Turner sign. So you turn the patient to one side and you see these signs. Okay, then yes, vitals unstable will go more in favor of ruptured ectopic pregnancy. Very good. Hypotension, weak pulse, tachycardia will go more in favor of ruptured ectopic. But vitals will become unstable if there is massive bleeding. So whether the vitals are stable or unstable will depend upon the amount of blood that has been lost. Right? So vitals, however unstable, go more in favor of diagnosis of ruptured ectopic. On your per-vaginal examination, we will just be able to feel some bogginess through the fornices. Bogginess felt through the fornices. Okay, because blood collects in the pouch of Douglas first. That is the most dependent part of the pelvis. Remember that? Right? So just bogginess felt through the fornices because of blood in pouch of Douglas. Okay, keep that in mind. Now, if these are your findings and ultrasound tells you that the uterus is empty and there is nothing but peritoneal collection, the peritoneal collection present, okay, this peritoneal collection is going to be blood only, then if these are your features, the diagnosis is ruptured ectopic. Ruptured ectopic. All right, keep that in mind. All right, now it's 6:35 now. We're going to take a quick break of 15 minutes and we're going to be back after a break in 15 minutes. So let's see you guys in 15 minutes. In the meanwhile, if you have any queries, you put them up in the chat box. Once we resume, we can take up those we can take up your queries as well. Okay. So, hello friends, welcome back after the break. So, you can put it in the chat box if you are ready with the session. Yes, are we back? Yes, yes, yes. Okay, all right. So, Shivam, we spoke about this in the beginning of the lecture also, but I don't know if you were there listening. But, anyways, I will again specify for you. Uh, When we dilate the cervix and then curate out the contents using a uterine curette, the procedure becomes dilatation curettage. When we dilate the cervix and then we go for evacuation of the contents of the uterus by using a suction cannula, which is a Carmen's cannula, then the procedure becomes suction and evacuation. Suction and evacuation, typically we use the electric suction machine in the OT. If you're creating suction using a handheld vacuum aspiration device, it is called as manual vacuum aspiration. And dilatation and evacuation is basically we dilate the cervix and then we evacuate the uterine contents using instruments like ovum forceps. Then that procedure is dilatation and evacuation. Okay, fine. And then we have this doubt that has been posted by S that yes, you're right saying that anovulatory cycles are typically painless, but in the absence of any pathology, right? So you say in PCOS, yes, patients can experience painful periods also despite there being anovulatory cycles, because in PCOS the ovaries are enlarged also and there is some degree of pelvic congestion also. So any factor which leads to pelvic congestion could be because of enlarged ovaries like in PCOS, or pelvic congestion because of PID also. Then also there can be painful periods. Okay, so pelvic congestion, that's the important point there. Okay, fine. And you already have answered SNC. S and Priyaraj already answered that which of the following is an indication for surgery in ectopic pregnancy for a woman who is desirous of another pregnancy. So you are rightly saying that if the serum beta HCG levels are less, it's an indication for medical management can be done. Patient wants to continue the pregnancy, that's absolutely no point at all. If it's an ectopic pregnancy, there's no continuation of pregnancy. If it's an unruptured ectopic pregnancy, yes, medical management can be done. But if it's an ectopic pregnancy with a mass size that is more than 4 centimeter, it's an indication for surgery, right? Clearly that is an indication for surgery. So that's your answer there. So to summarize the clinical management of ectopic pregnancy, if it's a ruptured ectopic, okay, if it's a ruptured ectopic, management is resuscitation plus surgery simultaneously. Okay, and surgery will be done in the form of salpingectomy. We have to do a salpingectomy. There is no saving of the tube here. And if the patient is stable, we can go for laparoscopy. Laparoscopy can be done. Okay, and if the patient is unstable, then laparoscopy is not an option. Then we have to go by laparotomy only. Then laparotomy is the only option. Okay, fine. Now, if it's an unruptured ectopic pregnancy, medical method can be done as well as surgical method can be done. Okay, medical method we are generally doing if the woman is having her first pregnancy and that happened to be an ectopic pregnancy. So basically medical management is done to save the tube, in an effort to save the tube. But then she has to be stable, motivated and compliant patient. That is very, very important, because she has to come for follow-up as well. So that is very, very important, first point, right? And then there should be no contraindications to methotrexate, because the drug of choice is methotrexate, and all of these should be present. HCG should be less than 5,000, cardiac activity should be absent, and the sac size should be less than 4 centimeter. If all of these are there, then only medical management can be done. Surgical management in an unruptured ectopic pregnancy. Well, if the woman has completed her family, she doesn't want to have any more children, then you can do a surgical management. Okay, then surgical management is preferred. If there is any contraindication for methotrexate, then also surgical management is done. And if medical management fails, then also surgical management is done. In this surgical management, there are two options. One is salpingectomy, that is removal of the tube, and the other is salpingostomy. Salpingostomy. Salpingostomy means that we give an incision over the tube, we scoop out the ectopic, and we leave the incision open. Okay, we don't put stitches on the incision. Okay, that is ostomy, create a stoma. So both are options, both are fine. Salpingectomy and salpingostomy, anything can be done. All right, it will depend on a case-to-case basis. So both are options for surgical management in unruptured ectopic pregnancy. Now, let's have a look at the next question. A woman is seen at 11 weeks of gestation with complaint of mild spotting. Ultrasound reveals a gestational sac of 5 weeks gestation only with no fetal pole inside. What is the diagnosis? Yes, what is the diagnosis now? She is 11 weeks, but the gestational sac is small only. It is only 5 weeks gestational sac, they are saying, with no fetal pole inside. What is the diagnosis? It's an empty gestational sac. An empty gestational sac which is more than or equal to 25 mm, right? Or let's say if there is a fetal pole there, fetal pole is present which is more than or equal to 7 mm, and yet there is no cardiac activity, then these are the two situations where we will call it as a missed abortion or early pregnancy loss. Missed abortion or early pregnancy loss. Okay, fine, keep that in mind. Now, let's say incomplete abortion. It's not an incomplete abortion, bache. Where is the history of bleeding? There is a sac there inside. There is a sac there inside, and the patient has only complaint of mild spotting. Incomplete meaning that some products got expelled. That history is not there. That history of expulsion of products is not there. That history of bleeding is also not there. Just mild spotting. Patient may very well be asymptomatic. Patient could have been asymptomatic and could have come for a routine ultrasound. And on ultrasound, there is an empty gestational sac. Right? Because it is not corresponding. Na? It's 11 weeks. But the gestational sac stopped growing at 5 weeks of gestation. After that, there is no fetal pole that developed inside at all. So this is missed abortion or early pregnancy loss. Keep that in mind. Very, very important pointer. Okay. So I have given you how to make the ultrasound diagnosis of missed abortion or early pregnancy loss. Clinical symptoms like this. Just mild symptom, mild spotting, maybe some lower abdominal pain. She may be asymptomatic also. The diagnosis of missed abortion or early pregnancy loss is made on ultrasound only. Keep that in mind. So what about the other types? Threatened, incomplete, inevitable. So let's summarize them. Okay, let us now summarize them. How will you get the questions? So in a threatened abortion, what happens is that there is right now just a threat of abortion. The process of expulsion of products, that has not started yet. Okay, so the bleeding PV is only mild. Okay, maybe just spotting, pain could be there, could not be there, pain could be there, could not be there. Vitals, the vitals, hemodynamic stability will depend upon the amount of blood loss. Okay, so here only mild spotting is there, so vitals are stable. What about the size of the uterus? Size of the uterus is going to correspond to the period of gestation. Let's say she is 8 weeks, then the uterus size will also be 8 weeks. The size of the uterus is going to correspond to the period of gestation, and the os, the cervix, is going to be closed because the process of expulsion of contents has not started yet. So os is going to be closed. In this situation, you are going to confirm with transvaginal sonography, because on transvaginal sonography, what will be seen? There will be a fetus or an embryo with cardiac activity present. Okay, this is going to be this thing. Okay, right? So fetus or embryo with cardiac activity is going to be present. Okay, S, these are all buzzwords. Okay, these are all buzzwords. Now in inevitable, what will happen? Inevitable meaning that the process of expulsion has started, but the all the contents are still inside the uterus. That is what inevitable means. Process has started, it is going into abortion only, there is no going back, but all the contents are still inside the uterus. So bleeding will be more, pain will also be there, vitals will be stable or unstable. That will depend upon how much blood she has already lost. Okay, so vitals could be stable, could be unstable, depending on that. What about the size of the uterus? All content still inside. So size of the uterus is going to correspond to the period of gestation. The os is going to be open because the process of opening of os has started. Contents are still inside, but os has started to open up. Okay, sometimes bulging membranes can also be felt through the os. Okay, so on transvaginal sonography, whether we do it or we don't do it, it doesn't matter. Okay, the fetus or embryo is going to be inside, the embryo inside, cardiac activity could be there, could not be there, it doesn't matter. The os has already started to open up. Okay, now so the buzzword here is going to be, talking about the buzzword S, size of the uterus corresponding to period of gestation. The os has started to open up, it is an inevitable abortion. What about incomplete abortion? In incomplete abortion, again, what does it mean? It means some products got expelled, some are still left inside. That is incomplete. Okay, so then bleeding will be more, history of bleeding will be more, pain will also be there. Okay, and vital stable, unstable, depending upon how much blood she has lost. Okay, so same. But what about the buzzwords? The buzzwords now would be that if it's incomplete, that means some products got expelled. So the uterus size will be smaller. The size of the uterus is going to be less than the period of gestation. Size of the uterus was going to be less than the period of gestation, and the os is usually going to be open. Os is usually going to be open. So this is your buzzword. Okay, keep that in mind. Os is usually going to be open. Let's compare now. S, let's compare now. People who had answered incomplete abortion in the previous question. Where was the history of bleeding? Where was the history of bleeding? It wasn't there. That's why it was not fitting into incomplete abortion. Keep that in mind. Okay, even though in a missed abortion also the size of the uterus is going to be less than the period of gestation. Yes, but profile of the patient, where is the history? So that history has to be there. Bleeding history, pain history has to be there. All right, and the os is usually going to be open in incomplete abortion. And on sonography, what we are going to find? We are going to find some products, POCs, period of products of conception. POCs is the short form of products of conception inside the uterus. Okay, some products of conception are going to be found inside the uterus. What about incomplete abortion? Incomplete abortion, history of bleeding will be there, history of pain would be there, maybe some history of product passage of fleshy mass is also there. History of passage of fleshy mass from the vagina is also there, but now the bleeding has stopped. So there is going to be a history of bleeding, history of pain. She may have a history of passage of fleshy mass from the vagina, right? But now all those symptoms have stopped because the uterus got emptied. Once the uterus is emptied, bleeding has stopped, right? So keep that in mind. Stable, unstable, depending upon how much blood she has lost in the process. Okay, period of gestation less than the uterus size less than the period of gestation. Os is going to be closed. Os is going to be closed. And on transvaginal sonography, the uterus is going to be empty. On transvaginal sonography, the uterus is going to be empty. Okay, so these are your buzzwords here instead of mugging up the buzzwords, because I'll tell you why. Because you'll get confused once you have so many things to mug up. You get confused kisme, which had os open, which had os closed, and everything. You forget, which is very natural. So remember it conceptually. Threatened, just a threat is there. Everything else is fine. The fetus, embryo, cardiac activity is still inside. So obviously the os is closed. The uterus's size is corresponding to period of gestation. Inevitable process has started, right? But expulsion has not yet started. Os is open, but everything is still inside the uterus. So uterus size corresponds to period of gestation. Incomplete, some products are still left inside, and some products have already been expelled. So os is usually open and period of gestation is going to be less. Complete, the process has gotten completed. So the uterus is now much smaller in size, the os is closed, and the uterus on transvaginal sonography is going to be empty, right? So you don't need to mug this up, but remember it is all there in the words itself: threatened, inevitable, incomplete, and complete abortion. Keep that in mind. Now, one more scenario we are going to do. Let's say that there is a situation where a woman has amenorrhea. Okay, she may have some symptoms like bleeding or pain or something, or she may be asymptomatic. Doesn't matter. She may have some symptoms, she may have no symptoms. Urine pregnancy test is positive. Okay, urine pregnancy test is positive, but transvaginal sonography shows no gestational sac anywhere. Transvaginal sonography shows no gestational sac anywhere. So now you don't know where is the pregnancy. You don't know if it is in the uterus, if it is in the adnexa, because ultrasound is not showing anything. Then in that situation, we go for a serum beta HCG. Serum beta HCG levels. If your serum beta HCG levels are less than 3500 international units per liter, or the serum beta HCG levels are going to come out to be more than 3500 international units per liter. If the levels are less, okay, then we repeat these serum beta HCG levels every 48 hours, to see the trend of serum beta HCG. Okay, if the serum beta HCG levels are doubling, remember doubling time of serum beta HCG, every 48 hours serum beta HCG level doubles in a healthy intrauterine pregnancy. So if the levels are doubling, then it is most likely a healthy intrauterine pregnancy. Keep that in mind. Okay, IUP, intrauterine pregnancy. If the levels are falling levels by about 50%, then it is most likely an abortion. Okay. And if the levels are plateauing, then it is most likely an ectopic. Pregnancy. So remember these important pointers. Okay, so plateauing HCG levels, more likely ectopic, and you have to see them every 48 hours. If it is beta HCG levels more than 3500 international units per liter, so much of beta HCG, but the sac is not seen anywhere, then it is most likely an ectopic. Maybe it is a very small ectopic which we are not able to see on ultrasound. Okay, please remember, if we are not seeing something on ultrasound, then doing laparoscopy makes no sense, because in laparoscopy all we are going to see is the outside of the fallopian tube, the outside surface of the uterus on laparoscopy, right? So if ultrasound is not picking it up, then laparoscopy offers no advantage, because if it's too small a pregnancy to be picked up by ultrasound, laparoscopy gives no such advantage. So in this situation, laparoscopy will not help. Keep that in mind, right? So most likely it is going to be an ectopic, and we can start with medical management of ectopic. Dr. Akhil, plateau meaning it's not doubling and it's not even falling more than 50%. That's why plateauing. Okay, maybe rising but not doubling, maybe falling but not falling enough, plateauing. Okay, so that is plateauing. Okay, now let's have a look at the next question. A 25-year-old primey came at 32 weeks of gestation. She is sure of her dates. Symphyso-fundal height is 28 centimeters. BP is normal. There is no history of leaking or bleeding. She is not perceiving fetal movements for 2 days. Fetal heart sound cannot be localized on stethoscope. What do you want to do next? What do you want to do next? Yes, what do you want to do next? Non-stress test, ultrasound, fetal Doppler, or biophysical profile? What do you want to do next? Yes, so here look at the history. The uterus is less, the size of the uterus is less than the period of gestation. Okay, she's not even perceiving fetal movements for 2 days. Fetal's heart sound cannot be localized on stethoscope. What happened? Maybe the fetus is already dead. We don't know. So first of all, confirm. She could be an IUD. So, बच्चे NST का क्या मतलब? अभी S and फतेहपुरिया. A NST. ठीक है? Okay. NST. You can't localize the fetal heart sound on ultrasound, on stethoscope. You have an NST probe. Okay, you want to put her on the maternal abdomen and keep localizing, keep finding, keep looking for the fetal heart, because NST is also going to pick up na thak 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 fetal heart rate. So NST se kya hoga? First you have to know bhai whether the fetus is alive or not, isn't it? So ultrasound is important right now. Ultrasound is important right now. Very, very important point to note. Okay, clear. So let's see. If your fundal height is less than the period of gestation, she could be wrong dates. She could be wrong dates. She could be having oligohydramnios, decreased amount of amniotic fluid. Now, she could be having oligohydramnios because of some or the other reason. We have this whole lot of causes which lead to oligohydramnios. She could be having fetal growth restriction. She could be having decreased amount of amniotic fluid because she has had leaking and because all the liquor has already leaked out. That is why we took the history of leaking also. That is why we took the history of leaking also. Isn't it? So she could be having oligohydramnios because of n number of causes that leads to oligohydramnios, or she may have had a history of leaking because of which all the liquor leaked out, and that's why the fundal height is less than the period of gestation. She could be having a fetal growth restriction, or she could be having an intrauterine fetal death. So you are going to find out by ultrasound. You're going to find out by ultrasound. What you see on ultrasound, then you will decide what to do next. Whether on ultrasound you find that the baby is already dead, or you have fetal growth restriction, then you'll start doing, Doppler, NST, and all of those things, right? If the fundal height is more than period of gestation, what are the possible causes? That's also another MCQ for your exams. Again, same thing. She could be having wrong dates. Sometimes women are examined with full bladder. If there's a full bladder in front, it pushes the uterus upwards, so you can have a false estimation of fundal height which is more than the period of gestation. If you have multiple pregnancy, if you have a molar pregnancy, if you have excessive amniotic fluid, if you have a fibroid uterus, these are all causes of fundal height more than the period of gestation. You can find out by an ultrasound, right? So first an ultrasound, it will help you make a diagnosis, right? So ultrasound makes logical sense before we do anything else. Okay, fine. Chalo, let's have a look at the next question. Now, a woman came with 10 weeks of amenorrhea with severe nausea and vomiting. Size of the uterus is 12 weeks. Size of the uterus is 12 to 14 weeks. Ultrasound shows snowstorm appearance. Often repeated question in FMG. Often repeated question in FMG. One way or the other, they ask you question about molar pregnancy. With bilateral theca lutein cysts also. What is the management? They could ask you what is the diagnosis. They can ask you what is the next step. They can ask you whether it is a complete mole or a partial mole. So when you see this snowstorm appearance, okay, snowstorm appearance means inside the uterine cavity, fetus is not there. There is no fetus inside, just swelling of chorionic villi. Okay, so many cysts, round cysts are seen inside. This is called as classic snowstorm appearance. This is seen with complete mole. So your diagnosis, if they ask you in this question, diagnosis is complete mole, right? So what is the management they're asking you? Very good, Jitendra and S. Management is suction and evacuate. Very good. No medical management. In the option, they could have given you misoprostol, this and that. No medical management, no oxytocin, nothing. Suction and evacuation. Even if there are bilateral theca lutein cysts, no problem. These cysts, they regress on their own after the molar pregnancy is evacuated. Okay, because what is the source of these theca lutein cysts? What is the source of these theca lutein cysts? You see, these, there's this massive proliferation of chorionic villi. So there is excessive beta HCG. Excessive beta HCG coming from these chorionic villi. So this excessive beta HCG is responsible for the severe nausea and vomiting. Okay, this excessive beta HCG can act like LH. Beta HCG can act like LH and stimulate the theca cells of the ovarian follicles, and then can lead to theca lutein cysts also. So once the pregnancy is treated, once the suction evacuation is done and the contents of the cavity are removed, that means the chorionic villi inside are removed, then the theca lutein cysts are going to regress on their own, isn't it? So until unless there is some ovarian torsion, until unless there is some surgical emergency, there is no need to specifically treat these theca lutein cysts separately. Okay, so suction and evacuation is your answer here. All right, so clinical presentation, woman will be in her first trimester or second trimester. She can have severe nausea, vomiting. She can even have bleeding. The profile could change. The profile could say that she is having some bleeding, okay, vaginal bleeding. Okay, she may give a history of passage of grape-like vesicles. Okay, right? The uterus size is usually going to be more than the period of gestation, but it could be the same size also. It could be the same size also, or it could be smaller also. So it's not hard and fast that the uterus is always going to be more than the period of gestation, but it is more than the period of gestation. We do an ultrasound shows a snowstorm appearance. Your diagnosis of complete mole is made. Fine, keep that in mind. Okay, and one investigation that I would like to do before a suction and evacuation, always do a serum beta HCG. Okay, because after the evacuation we have to follow up with serum beta HCG, and we have to follow up with serum beta HCG levels weekly till the time we get negative beta HCG value. So a long follow up is required. But follow up to tabhi hoga na when you will have some baseline value na to compare it with. So always send a serum beta HCG before a suction and evacuation, because after evacuation we have to do follow up with beta HCG levels. That much you should remember. Now, just a little bit of more information about the kind of questions that have been asked from gestational trophoblastic diseases. When we say gestational trophoblastic diseases, there is abnormal proliferation of placental trophoblasts. Okay, so benign forms of gestational trophoblastic diseases are what we call as the molar pregnancy, in which there is complete mole and partial mole. Okay, and the malignant forms of gestational trophoblastic diseases are called as gestational trophoblastic neoplasia or GTN. Okay, now these GTN include invasive mole, that is most common, choriocarcinoma, that is second most common, and these two, they are extremely rare. Placental site trophoblastic tumor and epithelioid trophoblastic tumor, these are extremely rare. Remember that. The marker for these gestational trophoblastic diseases is serum beta HCG. Marker is serum beta HCG, except for these. These they usually don't have raised serum beta HCG levels. Okay, they usually don't have raised serum beta HCG levels. So the marker for placental site trophoblastic tumor is going to be human placental lactogen, that is raised. Okay, or placental alkaline phosphatase. Placental alkaline phosphatase. Placental alkaline phosphatase. Okay. Then they ask you two direct MCQ pointers. Two direct MCQ pointers I'm going to give you. They ask you choriocarcinoma. If they ask you choriocarcinoma develops most commonly after what pregnancy? Please remember that GTN can occur after any pregnancy event. After any pregnancy event. Whether abortion, whether ectopic, whether full-term delivery, whether molar pregnancy. But most commonly GTN occurs after, a molar pregnancy. After a molar pregnancy. Arey bhai, that is why we were following up. Molar pregnancy evacuations with beta HCG. वरना क्या जरूरत है? Why do we need to follow up molar pregnancy evacuations with beta HCG? Because we know that most commonly GTN develops after a molar pregnancy, and the marker of GTN is beta HCG, right? So during molar pregnancy follow-up, if beta HCG levels are rising, and then we can make the diagnosis of GTN very, very easily. That is why we are following after molar pregnancy evacuations, right? So most commonly GTN is invasive mole followed by choriocarcinoma. So if they ask you choriocarcinoma develops most commonly after, answer is molar pregnancy. Answer is molar pregnancy. Okay. But if they ask you woman developed GTN after a full term pregnancy. Dekho, question changed. Okay. Now they are asking you that there is a woman who developed GTN after a full term pregnancy. Then it is 99.9% a choriocarcinoma. It is almost always a choriocarcinoma. Okay. So these are important pointers you need to keep in mind for MCQs. Okay. Fine. Now, other important MCQ pointers. Complete mole versus partial mole. Very, very important direct MCQs asked from this topic. Okay. So complete mole is a diploid. Molar pregnancies are basically abnormal fertilizations. Okay. So what happened in a complete mole? There was an empty egg and that got fertilized with the sperm. Empty egg got fertilized with the sperm. So sperm DNA is there, and here there is empty egg. Okay, empty egg is there. So it gave rise to a zygote, and the sperm DNA duplicated. Okay, the sperm DNA duplicated. So it is diploid, but mostly monospermic. Single sperm fertilized empty egg, and then the sperm DNA duplicated. So mostly monospermic, diploid, and most commonly 46XX. Another MCQ pointer, most commonly 46XX. Partial mole on the other hand is triploid. How is it triploid? There was an egg, so there was this egg DNA, then there were two sperms, dispermic, which fertilized this egg, and we got a conceptus with maternal DNA and with paternal DNA also. We got a triploid conceptus. So this triploid conceptus dispermic is a partial mole. Keep that in mind. So partial mole is triploid. So it is going to have 67 chromosome. Enough. It will not be 46. It will be 67. Karyotype will show 67 pairs, 67 chromosomes. Okay. This could be 67XXY. It could be 67XXX. or 67XYY. I mean, there can be various permutation combinations also here. Then the other important point you should notice, what about the fetal tissue or embryonic tissue? In a complete mole, fetal tissue is completely absent. There is no fetal or embryonic tissue, and there will be partial mole, it will be present. The hydropic degeneration of chorionic villi in case of complete mole is going to be complete and extensive. Complete and extensive. Here it is going to be incomplete hydropic degeneration or partial hydropic degeneration of chorionic villi. The chorionic villi that are formed in complete mole. In complete mole, there is no fetal tissue that is forming. Why? Villi are vascular because of fetal vessels inside them. So vascularity is going to be completely absent in case of complete mole. The vascularity of villi is going to be completely absent. And in partial mole, there is going to be vascularity in some parts. Vascularity in some parts. 69, sorry. 67 I wrote here. 69. Okay. Okay. So 69 chromosomes because it is triploid. And what are you asking? XXX. Arey, to 3 sets of sex chromosomes, na baba? That is XXX. XY, 3 sets of sex chromosomes, like that. Okay. And then we have excessive beta HCG also in molar pregnancy. So in complete molar pregnancy, it is usually going to be more than 10 to the power 5 international units per liter, and in partial mole, it is usually going to be less than 10 to the power 5 international units per liter. Okay. And the conformation, whether it is a complete mole or a partial mole. See, complete mole is going to show snowstorm appearance. Okay, complete mole is going to show classic snowstorm appearance. Classic snowstorm appearance on ultrasound. Partial mole is usually going to be misdiagnosed as missed abortion. Partial mole is usually going to be misdiagnosed as missed abortion. So 100% confirmation, 100% confirmation will come with histopath only. Okay, when we are going to evacuate the molar pregnancy, we are going to send it for histopath. Histopathology will tell me whether there is hydropic degeneration of chorionic villi, whether the villi are vascular or not, whether there is any fetal or embryonic tissue or not. So that will be confirmed on histopath. So after molar pregnancy evacuation, okay, or let's say after a missed abortion has been evacuated, always and always we send for histopathology. We send the specimen for histopathology. That is very, very important to remember. Okay, now hydropic degeneration of villi means that first of all, the villi are extensively proliferative. Hydropic degeneration meaning that they are edematous and swollen also. That's what hydropic degeneration means. And degeneration because they are not adequately formed, right? So they are degenerated in that sense. Now, next question. A woman comes to the OPD with post-dated pregnancy at 42 weeks. What should be the next step in evaluation? Yes. What should be the next step in evaluation? Post-dated at 42 weeks. Next step in evaluation: induction of labor, review menstrual history, ultrasound, cesarean section. Think logically, think by using common sense. Yes, just plain simple common sense to answer this question. Okay, she has crossed her EDD. That's what post-dated means. Post-dated means crossed her EDD. Okay. Okay, so there is this doubt between induction of labor or cesarean section. Okay, agreed. But don't you want to really find out if she's actually 42 weeks? Don't you want to confirm? What if she was having irregular cycles? What if she doesn't remember her LMP correctly? What if it has been wrongly calculated? Don't you want to review the menstrual history before taking such decisions whether induction of labor or cesarean section should be done straight away? Right? Let's review the menstrual history. Let's see if there is a first trimester ultrasound available. Let's know for sure that yes, she is 42 weeks. Nahi? Don't you think that makes more logical sense? Confirm, right? So at this point in time, I mean, before deciding what to do, I would like to go for a review the menstrual history first of all, and then think about doing an ultrasound also, before actually going ahead with induction or a cesarean section or whatever. So review the menstrual history. Okay, there's nothing to that. This is plain simple logic. Okay, this is plain simple logic. Options options are not khatarnak, but come to think of it, yaar, agar, if you are in the OPD, some patient tells you, okay, doctor, my 10 months have gone by. I'm pregnant for 10 months. It's been 10 months. I should have delivered by now. You'll say, let me check, yaar, whether you are 10 months or no. Let me tell me what your LMP was. I'll calculate. Did you have regular period? Do you have an ultrasound from early pregnancy so that I can know what is your EDD? You would yourself do this before thinking that yes, she is 42 weeks, right? So coming back, concepts and question. When you calculate gestational age, you are counting from the first day of LMP. You're counting from the first day. Here, last menstrual period, first day when bleeding occurred, first day that bleeding started, that is from where you're counting. This is where she missed her period. Okay, you're not counting from here, you're counting from here. Okay, patients sometimes give you this date. No, we want this date. When was the last menstrual period? Okay, and that we used to calculate the gestational age. Okay, so 40 weeks is equivalent to 280 days. EDD, expected date of delivery, corresponds exactly to 40 weeks. Okay, now all this 37 weeks to 42 weeks, all this is term. Okay, when she has gone beyond 42 weeks, then we call it as post term or post maturity. By definition means that she has crossed beyond 42 weeks. Once she is beyond 40 weeks, when EDD is crossed, then we call it post dated. Post dated is simply meaning dates crossed, EDD crossed. Post dated does not necessarily mean post term. Post term is when she has gone beyond 42 weeks of gestation. That is by definition post term or post maturity. Then before that, before 37 weeks, everything is preterm, isn't it? Before 37 weeks is preterm. Before 37 weeks is preterm. Okay, if she goes into labor before 37 weeks, it is called as preterm labor. Okay, between 34 to 37 weeks, now these are MCQ pointers. Between 34 to 37 weeks, it is called as late preterm. If she is less than 34 weeks, then that is called as early preterm. And less than 20 weeks by definition is abortion. Less than 20 weeks by definition is abortion. You all know this. Okay, fine. Now, let's have a look at the next question. Which of the following infections to the mother does not cause fetal abnormalities? Cytomegalo, chickenpox, shingles, or rubella. Okay, which infection to the mother does not cause fetal anomalies? So any maternal infection, that infective agent can cross the placenta, reach the fetus, and can cause fetal malformations, okay, or fetal abnormalities. But which doesn't? That's an important question. Which doesn't? Okay, so shingles is, what is shingles? Shingles is herpes zoster. Okay, that happens because of reactivation of the chickenpox virus that leads to herpes zoster. Okay, so shingles does not cause fetal abnormalities. Keep that in mind. Even HIV does not cause fetal abnormalities. Remember that also. Okay, so shingles does not cause fetal abnormalities. HIV does not cause fetal abnormalities. Okay, keep that in mind. All right. Okay, yes, you're right. It's viral. In fact, you're right. Varicella zoster virus. So varicella zoster virus, primary infection causes chickenpox, and reactivant, latent infection which got reactivated at a later point in time causes herpes zoster. That is shingles. Virus is the same, varicella zoster virus. Good. Now, let's see the next question. Very, very important 3 questions I have given to you. Very, very important 3 questions. And the important point to note here is that, again, I don't advocate mugging up lists somehow, you know, because I feel that when you have MCQs to attempt in exams and you have to, you know, pick answer or choose answers in such a short duration, you have a minute or 2 minutes to answer a question. At that point in time, if you have lists to remember, mugged up list to remember, you generally waste time. So think logically. Which of the following is not an indication for emergency cesarean section? Okay, now think logically. Fetal distress, will you do an emergency cesarean section? Cord prolapse, will you do an emergency cesarean section? Oligo, will you do an emergency cesarean section? Or CPD in labor, will you do an emergency cesarean section? Right now, Mohit, before you, since you're pick up the you're writing the answers, I'll just take up Mohit's doubt. Chickenpox causes which abnormality? But these all these in fetal infections, chickenpox particularly causes neonatal varicella syndrome or congenital varicella syndrome. Okay, so in congenital, when it happens, when the infection happens early or in pregnancy, less than 20 weeks gestation, it usually leads to congenital varicella syndrome, where there is all these intracranial calcifications can happen, microcephaly can happen, so a variety of manifestations. Okay, or even, you know, limb scarring and, you know, all that. So basically that. Otherwise, you know, if a woman is having chicken pox, let's say a woman is term and she happens to have chicken pox and she delivers, you know, within 5 days of acquiring the infection, then the newborn could have neonatal varicella. So that is just chicken pox in the newborn period. So that is called as neonatal varicella. So that is, yes, S, shrinkage of fetal limbs. Yes. So can we do amnio infusion in oligo? I'll come to that as also. So which is not an indication for emergency cesarean section? Oligohydramnios. Very good. So oligohydramnios by itself. See, if there is decreased amount of amniotic fluid, why will I just like to do a cesarean section? I mean, by itself, it is not an indication to do a cesarean section. However, if there is fetal distress, yes, I would like to do a cesarean section. If there is a cord prolapse, yes, a cesarean section is justified. And if CPD in labor is there and woman is not delivering, cesarean section is justified. But by itself, oligohydramnios is not an indication for cesarean section, right? Right. And Mohit, yes, you're right. Torch infection, this whole group of torch infection is toxo, rubella, cytomegalo, herpes. So these are all as a group. These are called as torch infections, right? So torch infections, when a woman acquires those infections during pregnancy, they can lead to congenital malformations in the fetus. Now, as your question, can we do amnio infusion in oligohydramnios? Amnio infusion in oligohydramnios is something that is not recommended. Only and only under one circumstance. Only and only under one circumstance. Amnio infusion in oligohydramnios is only recommended if it is causing variable decelerations during labor. Otherwise, no. Otherwise, no. Okay. Now, next question. Absolute indication of cesarean section. What is the absolute indication? Where you cannot do anything else, but you have to do a cesarean section. Previous cesarean section, placenta previa, fetal distress, breech presentation. Now see, there is no list to mug up here. You have to think logically, because fetal distress was here also in the option. That was not an indication for emergency. That was that was an indication for emergency cesarean section. Here, things have changed. Now they're asking you what is the absolute indication of cesarean section, where you have to do cesarean section. What is the answer now? Think again. Jitendra Ness, think again. Placenta previa, placenta in the lower uterine segment. Placenta covering the os, placenta partially covering the os, placenta in the lower segment. Can you deliver the patient vaginally? Whether the patient is bleeding, not bleeding, doesn't matter. Just tell me, can you deliver the patient vaginally? So, Dr. Akhil, you're right saying. Anna, so placenta previa, there is no option of a vaginal delivery. When you have to deliver a case of placenta previa, it is always by a cesarean section. So, it is an absolute indication of cesarean section. Common sense answer. Previous cesarean section. Bhai, there are so many women with previous one lower segment cesarean section who have vaginal delivery after cesarean section. It's not an absolute indication for cesarean section. A previous cesarean section patient is not an absolute indication of previous cesarean section. Fetal distress. If fetal distress, now I'll tell you, and you know all this. You know all this. It's just that now you have to think logically. Fetal distress. Now let's say there is fetal distress in second stage of labor. Fetal distress in second stage of labor, patient is about to deliver. At that point in time, you can use instrumental vaginal delivery. Anna, you can do instrumental vaginal delivery at that point in time. So it's not an absolute indication of cesarean section. Breech presentation. Breech presentation, one can go for external cephalic version. Breech vaginal delivery can also take place. And one can go for cesarean section also. So breech presentation also is not an absolute indication of cesarean section per se. Okay. But yes, if there is footling breech, or let's say if there is breech with extended head, breech with hyper extended head, which is called as stargazer breech, then these are two situations where we go for cesarean section. Absolute indications of cesarean sections with breech. Keep that in mind. Okay. Now, next question. Which of the following is a contraindication to induction of labor? I am telling you whether they are asking you this question. The first we discussed. Whether they are asking you this question or whether it is this question. Essentially, the same logic is working. Now, look at this third question. Which of the following is a contraindication to induction of labor? When we do induction of labor means that woman is not in labor right now, but for some reason we feel that we should induce the labor, that she should deliver. Maybe for the mother's sake, she's having severe preeclampsia, she's having eclampsia, or for the baby's sake. Baby is having severe growth restriction or with all these deranged Doppler findings. Whether for the baby's sake, whether for the mother's sake, we have come to the decision that it is better for her to deliver. Then we go for induction of labor. Okay, we do induction of labor because we want to achieve a vaginal delivery. Okay, just think logically. We do a induction of labor because we want to give her a chance to deliver vaginally. Otherwise, हम तो cesarean कर देते. But that is not the thing. We are doing induction of labor with the goal of achieving a vaginal delivery. So any situation where vaginal delivery cannot be done, that will be a contraindication to induction of labor. Okay, so any situation where vaginal delivery can't be done is going to be a contraindication to induction of labor. So is post-term pregnancy a contraindication to induction of labor? Just by being a post-term pregnancy? No, post-term pregnancy, we can go for induction of labor. Severe preeclampsia, we can go for induction of labor. Prolonged rupture of membranes, we can go for induction of labor. But if there is previous two cesarean sections, we go for direct cesarean section in these cases. So previous two cesarean section, we go for direct cesarean section. It's a contraindication to induction of labor. Okay, so one thing that you need to remember here, yes, severe preeclampsia can worsen to DIC. That is why we have to check for DIC. And even if there is DIC, I don't want to operate with DIC. I'll correct for DIC. If I do a cesarean section and the woman is in DIC, she will start bleeding from the incision site. What will I do then? So DIC by itself is not an indication for direct cesarean section. देखो ये logic समझो. There are certain times in obstetrics, you don't have to remember the indications of induction. What is important to remember are when not to do. Right? Because सब जगह हम पढ़ते हैं preeclampsia, severe preeclampsia, eclampsia, where pregnant woman needs to deliver. Then induction of labor can be done, but there are certain situations, where induction cannot be done for obstetric reasons. I know you've read in textbook cesarean for obstetric indications. What are these obstetric indications? What are these contraindications to induction of labor? What are the situations where cesarean section is done instead when the need arises? Like maternal previous to cesarean section, Never induction, cesarean section. Previous classical cesarean section, an incision given on the upper uterine segment. Direct cesarean section. Are bhai, pelvis is inadequate. When the pelvis is only inadequate, then cesarean section done. Placenta previa, direct cesarean section. Active genital herpes in the mother. Genital herpes, mind you, genital herpes. And this is, we're talking about active genital warts or maybe active genital herpes simplex lesions, whatever. Because what can happen is that during vaginal delivery, the newborn can get infected. That's a problem because the newborn can have disseminated herpes infection. So we don't want that. So active genital herpes, cesarean section done. Okay. Now, fetal indications for cesarean section or contraindication to induction of labor, they are the same thing. Significant macrosomia. Ab significant macrosomia ka kya matlab hai? What is significant macrosomia? If the mother has diabetes mellitus and the estimated fetal weight is more than 4.5 kg, and if the mother has no diabetes mellitus and the estimated fetal weight is more than 5 kg, then a cesarean section is preferred. Okay, then a cesarean section is preferred. That is what significant macrosomia means. See, macrosomia by definition is more than 4 kg weight of the fetus. But significant macrosomia, how significant, I have told you. Okay, now which malpresentations? Transverse lie. We go for direct cesarean section. Bro presentation, mento posterior, we go for direct cesarean section. And if there is fetal distress, non-reassuring fetal status, then that depends. Okay, that depends in which situation we are going to see the woman. Okay, so if we are going to, let's say the woman is not in labor and already she's having fetal distress, then there is no point inducing the labor. Agreed. So non-reassuring fetal distress status in that situation is a contraindication to induction of labor. Okay, and then there is another situation where direct cesarean section is done for fetal indication. Monochorionic monoamniotic twins. Okay, in this situation there is very high risk of, there is no separation in between the twins, so the cords can get entangled, fetal parts could get entangled, so we can't allow them for vaginal delivery. Then also we go for an elective cesarean section between 32 to 34 weeks after giving a steroid cover, for pulmonary maturity of the fetus. Okay, all right, fine. Now it's viral and fact. Non-diabetic macrosomia, vaginal delivery can be done, and your diabetic woman with macrosomia, vaginal delivery can also be done. Okay, so only in these situations when the estimated fetal weight is more than 4.5 kg and the mother is diabetes, or the mother has no diabetes and the estimated fetal weight is more than 5 kg, then cesarean section is preferable. Cesarean section is offered to the woman. She may choose it, she may not choose it also. So cesarean section is preferable in these circumstances. Okay. Now, next question. Bishop score include all of the following except. Yes, what is not included in Bishop score? Cervical dilatation, cervical effacement, position of the cervix, shape of the maternal pelvis. So what's your answer? And what is this Bishop score used for? So Bishop score is done before we go for induction of labor. Okay, so in Bishop score, what do? We do a pervaginal examination and we look at the cervical findings. Okay, shape of the maternal pelvis has got nothing to do with it. Shape of the maternal pelvis is not included in Bishop score. Okay, so Bishop score is used for assessing the favorability for induction of labor. That is what Bishop score is used for. Okay, Bishop score is used for assessing the need for cervical ripening agents. Need for cervical ripening agents. Okay, when we go for induction of labor, we can use cervical ripening agents also to help ripen the cervix. Okay, so if the cervix is going to be long, uneffaced, os is going to be closed, the cervix is very firm, right? Then first we'll have to ripen the cervix. Okay, then only we can expect that the cervix is going to dilate. So it is used to assess the favorability for induction of labor and need for cervical ripening agents. So you need to remember here that Bishop score includes 5 things. Okay, 5 things. The 5 things are cervical dilatation, effacement in percentage, the station of the presenting part, the consistency of the cervix, and the position of the cervix. Okay, so cervical dilatation and effacement, they go together. Okay, once we are doing a per-vaginal examination, we can feel for the consistency of the cervix and the position of the cervix as well. So these are 4 things that we see. In addition, the 5th thing that we see is station of the presenting part. So look at the things that I have highlighted in red. See, a score of 1 here given to cervical dilatation 1 to 2 centimeters. Okay, 60-70% effaced, score of 2. Then station -1, score of 2. Consistency soft, position anterior, score of 2. So all in all, when the points that I've highlighted are red, that is my way of remembering the Bishop score. Otherwise, even I can't, mug up this entire Bishop score tablet, the table. Okay, so my idea is that I remember a PV finding: 1 to 2 centimeters cervical dilatation, 60-70% effaced, station -1, soft anterior cervix. All this 1, 2, 2, 2, 2. The total score for this red finding is a score of 9. That is how I remember. Okay, so the maximum score possible is 13. A score that is more than or equal to 6 is favorable. A score that is 9, that's why I remember 9. 9 means that there's a high likelihood of successful induction. If the score is less than or equal to 4, that means there is definite need for cervical ripening agents. Okay, keep this in mind. Then we have a modified Bishop score. We have a modified Bishop score. Okay, in the modified Bishop score, it is the same. It is the same except for effacement. Instead of effacement in percentage, okay, we use cervical length measurement in centimeters. Cervical length measurement in centimeters, that is the difference. And this cervical length can be seen on transvaginal sonography. This is modified Bishop score. And thirdly, for MCQ purposes, there is a simplified Bishop score also. Simplified Bishop score. Simplified Bishop score simply means that we see the 3 most obvious things. The 3 most obvious things are dilatation, effacement, and the station. If we are seeing only these 3 things, it's a simplified Bishop score, because consistency sometimes can be difficult to judge, position sometimes can be difficult to judge. So if we are going to see only 3 things, it is called as a simplified Bishop score. Okay, so keep that in mind. Now let's have a look at the next question. A 26-year-old primee is admitted for induction of labor at 41 weeks of gestation. She is sure of her LMP and has regular cycles. The uterus is relaxed, NST is reactive, and on vaginal examination, the cervix is uneffaced and the os is closed. What should not be done? Yes, what should not be done? What should not be done? So there are various methods of cervical ripening. Okay, when you read your textbook, there are various methods of cervical ripening. There is prostaglandins. We can use intracervical Foleys can also be used. Okay, and most of the times we are preferring prostaglandins. Okay, right? So which is not used? So not used is PGF2 alpha. Very good S. PGF2 alpha, this analog is not used in induction of labor or for cervical ripening. It is used to control bleeding in PPH cases Please remember PGF2 alpha analog, that is carboprost, which comes under the name of hemabate also. This is not recommended for induction of labor. Okay, now intracervical Foley's can be done. Intracervical Foley's placement is a very good method, in women with previous cesarean section. You see, when there is previous cesarean section, I don't want to use drugs, I want to avoid drugs. So intracervical Foley's is a mechanical method. Okay, the bulb of Foley's is inflated inside the cervical canal. That is what is done in intracervical Foley's method. So remember this much, it is a very good method in women with previous cesarean section. PGE1 is misoprostol. PGE1 is misoprostol. Okay, so misoprostol PGE1 tablet can also be used, but for induction of labor, it is an off-label use. It is an off-label use, and the dose is very less, 25 micrograms per oral. 25 micrograms per oral. That is a very small dose. Okay, so PGE1 tablet can also be used, and please remember it is contraindicated. PGE1, remember, PGE1 is contraindicated in women with previous cesarean section. Okay, keep that in mind. Another important pointer. Then PGE2 gel is what we call as dinoprostone. PGE2 gel is what we call as dinoprostone. This can also be used for induction of labor, then basically cervical ripening. And I don't want to use dinoprostone that often in previous cesarean section cases. If at all, I can use one dose, but generally I will not prefer. That's why I told you that intracervical Foley's is a very good method if induction is required in a woman with previous one cesarean section. Okay, with two, so I will not give induction only. I will go for direct cesarean section. Okay, and you are right, this comes as under the name of Serviprime gel. Dinoprostone is the compound, trade name Serviprime gel. You are right. Okay. All right. Now, next question. All of the following drugs are used in PPH management except. All of the following drugs are used in PPH management except. Yes, oxytocin, prostaglandins, mifepristone and tranexamic acid, which is not used. Yes, oxytocin is also used, prostaglandins are also used, tranexamic acid is also being recommended now, but tranexamic acid is an antifibrinolytic drug. Okay, so it is being recommended, but it is not a uterotonic. Okay, it is not going to replace uterotonics, but tranexamic acid is also recommended. Mifepristone on the other hand, no role. Mifepristone on the other hand, no role in PPH management at all. So what are your uterotonic drugs? Very, very important. Remember this table, questions asked, quick revision of the table. Okay, so these are your list of oxytonic drug or uterotonic drugs on one side. Then there are certain drugs which are recommended for active management of third stage of labor, certain drugs recommended for PPH. There are important side effects and important contraindications of those drugs that you need to note. Oxytocin is the drug of choice for active management of third stage of labor, or uterotonic of choice for active management of third stage of labor. 10 units IM or IV infusion can be given. What we are doing, we are recommending 10 units intramuscular injection. Please remember, oxytocin is never given. Very, very important MCQ pointer. Oxytocin should never be given by IV bolus. IV bolus injection of oxytocin is never given. Otherwise, it can lead to dangerous hypotension, tachycardia, can even precipitate myocardial infarction. So it can become very dangerous if given IV bolus. If at all IV, it has to be IV infusion, never IV bolus. Keep that in mind. Oxytocin in case of PPH is given in 20 units in 500 ml. IV infusion is given. Okay. Now, when oxytocin is used in very high dosages, which in clinical practice we generally don't go to. Okay, very, very high dosages, and for prolonged duration of time, if we have given oxytocin along with a lot of fluid infusion, if we have done, then it can lead to water intoxication. This water intoxication simply is because of the ADH-like action of oxytocin in high dosages, antidiuretic like hormone action, but in very high dosages. Clinical practices में ये नहीं आती situation when we tend to use such high dosages, okay? But you need to remember water intoxication. So in this water intoxication, what will happen? There will be this, the tissues will be overloaded with fluid, okay? So she can have fluid overload like complications, like she can develop pulmonary edema, she may even develop electrolyte imbalances like hyponatremia. These are buzzwords, remember that. And sometimes even convulsions can set in if there is cerebral edema. Okay, so this is something dangerous, water intoxication, but again with very high dosages of oxytocin. We don't use them in clinical practice, or with prolonged IV infusions of oxytocin this situation arises. But you should know about this complication, water intoxication. Contraindications for oxytocin, none, no contraindications. Then methergin. Methergin is a drug, the dose is 0.2 milligram IM or IV. Methergin is methyl ergometrine. It is recommended for AMTSL. Yes, it can be used, but we generally don't prefer methergin because the chances of retained placenta with methergin are increased. The increased risk of retained placenta is there with methergin use. So generally we are not preferring methergin for active management of third stage of labor. It's a very good drug for PPH cases. The side effects are hypertension, vasoconstriction, which generally happen with IV dose, and always before methergin the contraindication should be ruled out, which are you have to remember the contraindications of methergin, very important. Hypertension, again, because it causes hypertension as a side effect, so you can't use it in hypertensive disorders, whether it is chronic hypertension, whether it is preeclampsia, eclampsia, or heart disease also, right? If there is going to be heart disease in a woman and she happens to have sudden hypertension, then heart failure can be precipitated. So heart disease also contraindication. It's a vasoconstrictor agent, so it can worsen peripheral vascular diseases, and it is also not preferred in Rh negative pregnancy. Then yes, you are right. Only contraction phase. Methergin causes tetanic uterine contractions, very intense tetanic uterine contractions, right? That you are right. Very good. Misoprostol is PGE1 analog. Now look at this. Somebody was asking me to give you the dosages. I have given you dosages of misoprostol everywhere. Okay. So look at this. For AMTSL, 400 to 600 microgram orally can be given. It is recommended. 800 micrograms sublingually for PPH is the recommended dose. These are WHO dosages. Okay. The side effects are fever, shivering, and nausea, vomiting. Most common side effect is fever. Absolute contraindications for misoprostol are not there, except of course when we are going to go for AMTSL and PPH, we are going to avoid using it in previous cesarean section cases, but it's not an absolute contraindication there also. So it's not in the list of absolute contraindications there. Now carbitocin, again very important for your MCQs. They have asked question on carbitocin in FMG also. They have asked question in NEET PG also, right? So carbitocin, we can write here on the side that it is, and it's not a contraindication, so I'll just write it on the side here. Right, so remember carbitocin is a octapeptide. Remember carbitocin is an octapeptide. It is a synthetic analog of oxytocin, synthetic long acting analog of oxytocin. Okay, so oxytocin is a nanopeptide and carbitocin is a octapeptide, right? So it is a long acting analog. You need to remember the dose. They have asked question in NEET PG also, so there is a very light possibility for repeat. Okay, so question on dose, 100 microgram IM, and it can be given intramuscularly or it can be given by slow IV injection also. Okay, then very important point to note, highlight it in this chart here, that PPH, for PPH it is not recommended. See, Carbetocin only and only for active management of third stage of labor. Not recommended for PPH management. Remember that, must know pointer for your exams. Okay, clear? And then we have this synthometrin drug. Synthometrin is a fixed dose combination between of oxytocin, oxytocin, metrin from methergin. Just remember one thing, it is recommended for AMTSL, but it is not recommended for PPH at all. Okay. Then carboprost, PGF2 alpha, not recommended for active management of third stage of labor at all. Carboprost recommended for PPH management, 250 micrograms IM. Dose is important. They have asked this question. Maximum 8 doses can be given in 24 hours, right? So that would come out to be 2 milligram of dose in 24 hours. If we keep giving 250 microgram, 250 microgram for 8 doses, if we keep giving, maximum 2 milligram can be given. Most common side effect, diarrhea. Circle it, highlight it. Most common side effect, diarrhea. And contraindication is bronchial asthma because it causes bronchoconstriction as a side effect. This is also an MCQ pointer. So there are various MCQ pointers in this chart. Okay, so very, very important to remember these uterotonic drugs. Okay, fine. Now let's have a look at the next question. A woman underwent bilateral internal artery ligation during PPH. Okay. Later she developed pain over the left gluteal region. Which artery is compromised? So you see here image-based identification of internal iliac artery ligation. So you can see here in this image, this is the common iliac artery. So I'll just write common iliac here. This is the common iliac artery. This is the external iliac artery. Okay, and this is the internal iliac artery, right? Internal iliac artery, and it continues as the anterior division. It continues as the anterior division. So it is the anterior division of internal iliac artery that is ligated. Okay, so you can see here in the image that there is this posterior division of internal iliac arteries. Okay, so this is the posterior division of internal iliac artery, which should be spared. Which should be spared. Very, very important point. Okay, because this posterior division also gives out this superior gluteal artery, my dear friends. Anatomy question, anatomy, Obs Gynae correlation. So this is posterior division needs to be spared because it gives off this branch, superior gluteal artery, which supplies the gluteal region. So in case this posterior division is ligated or it is not spared now, then we will compromise the vascularity of the gluteal region, and that will lead to gluteal region pain. So which artery is compromised? Superior gluteal artery. That's your answer here. So which artery is ligated? Internal iliac artery. Which division of internal iliac artery? Anterior division of internal iliac artery is ligated. Keep that in mind. And another MCQ pointer is that when we are going for these ligation procedures, the sequence of ligation procedure is, first we go for bilateral uterine artery ligation, then we go for bilateral ovarian artery ligation, and then we go for ligation of bilateral anterior division of internal iliac artery. Okay, so this is the sequence of ligation of the iliac arteries. Okay, so when we are ligating, okay, this is where the location of the uterine artery is, right? This is the tube. Okay, this is the ovary. All right, and this is where the anastomosis of ovarian and uterine branches. This is ovarian artery branches, and this is the uterine artery branches. Okay, so uterine artery is ligated somewhere here. Okay, at this point, and ovarian artery is ligated here. Okay, not at its origin. Ovarian artery is not ligated at its origin. Keep that in mind. Okay, now next question. A woman came to emergency with heavy bleeding 24 hours after a vaginal delivery. What is the likely cause? 24 hours after a vaginal delivery. Something that did not happen during the course of vaginal delivery, but happened beyond 24 hours. When heavy bleeding or when PPH happens beyond 24 hours of delivery, what it is called as What is it called as? This is secondary PPH. This is secondary PPH. This is secondary PPH. PPH beyond 24 hours of delivery. Okay. Till 12 weeks postpartum. Till 12 weeks postpartum. This is secondary PPH. Most common cause of secondary PPH, retained products. Retained products, retained placenta, retained bits of placenta, sorry, retained placental bits. Okay, so in which circumstance can we have retained placental tissue? Succensurate placenta, right? Succensurate placenta. So in succensurate placenta, what do we have? Look at this, identification of images. Identification of images. See, this is a succensurate placenta, succensurate placenta, where there is an extra lobe of placenta. Extra lobe of placenta is there, and the extra lobe is connected by a leash of vessels. See, this is the leash of vessels connecting the main placental body with the extra lobe. So this connecting leash of vessels is there. Image on the right, this is the velamentous placenta. Velamentous placenta. Velamentous means that the cord here, can you see in the image, is inserted on the membranes. Cord is inserted on the membranes, not on the main placental body. So here you can see on the membranes, what can you see? These are naked fetal vessels. See, these are naked fetal vessels which are traveling in the membranes. Naked fetal vessels which are traveling in the membranes. By naked mean that they are devoid of the connective tissue covering which is present in the umbilical cord. So what is this connective tissue covering of the umbilical cord? The connective tissue covering of the umbilical cord is Wharton's jelly. Okay, so the umbilical vessels are inside the umbilical cord and they are protected against compression because of the connective tissue covering which is called as the Wharton's jelly. It is the connective tissue covering of the umbilical cord which protects the umbilical vessels. Which protects the umbilical vessels. Now these are naked fetal vessels because see, you can see them branching and running along the membranes. Then yes, you are right, Bhargavi, this is circumvallate placenta. This one is circumvallate because in circummarginate you will not find this thick yellow rim. So this is circumvallate. This is circumvallate because there is a double fold of amnion and chorion, double fold of amnion and chorion here at the periphery of the placenta, which you will not see in the circummarginate. Okay, so circumvallate placenta, what is seen here? The chorionic plate is shorter. Again, chorionic plate shorter or smaller. So C for circumvallate and chorionic plate is shorter or smaller. Remember that. Okay. So this is about your image-based identifications here. Next question. A 40-year-old multiparous woman presents after 12 weeks postpartum, but her bleeding has not stopped. She recently underwent a DNC at a private hospital, but there is no relief. Her clinical examination is otherwise unremarkable. What could be the possible cause? Now think about it. This is a previous year FMG question. This is a previous year FMG question. Same to same. After 12 weeks postpartum, could it be normal lochia? Can it be normal lochia so long later? No, it can't be normal lochia. It can't be normal lochia. Right? Retained products. Why, she's already underwent a DNC. Hannah, let's say the DNC was performed. Obviously, if curettage has been done, of course, it's not retained products. Na? Right now, it's not retained products. Endometritis infection could be. But where is the history of fever? Where are the findings suggestive of infection? You know, so findings suggestive of infection are also not given in the question. So endometritis becomes unlikely. Endometritis becomes unlikely. The biggest clue here is that even after she underwent a DNC, there is no relief. Even after she underwent a DNC, there is no relief. DNC क्या होता है? When you curate out the endometrium, it generally leads to stoppage of bleeding. Okay, so that is a procedure called as therapeutic curettage also. Okay, so when we curate out the endometrium, the underlying vessels, the underlying spiral vessels which are supplying the endometrium, they undergo vasoconstriction. Okay, so it triggers therapeutic curettage also works. There is a thing called therapeutic curettage. If it is not working, if there is no relief after DNC, there is some pathology there. And the pathology that is most likely is GTN. Okay, the pathology is most likely is GTN, gestational trophoblastic neoplasia. Remember, I told you GTN can develop after any pregnancy event. Okay, and GTN is a situation which can develop after full term vaginal delivery also. And the most important presentation of GTN in those circumstances will be a bleeding that is not stopping, a bleeding that continues to occur after delivery, a bleeding that does not respond to conventional management. You're trying everything, you've tried drugs, you've tried hormones, you've tried DNC, but it's not working. The possibility of GTN should be kept in mind. So that's your answer. Okay, so bachche log, with this we finished off the session for today. Okay, we're going to meet tomorrow and we're going to take up questions tomorrow. Okay, so we're going to start again tomorrow and we're going to finish off the rest of the questions tomorrow. All right, so tomorrow same time, 5 p.m. All right, we're going to have another Obs session and Gynae session. All right, so we're going to do it there. All right, so I'm going to end the session for today. Okay, yeah, and I'll see you guys tomorrow at 5. Thank you so much.
Okay, am I audible, guys? I will also check the link and start.